turn on. I got.
No gavel? It's okay. No, it's okay. No, I'm good. Yeah, we'll work it out. Yeah. Good afternoon. First of all, let me welcome each and every one of you to the hearing, the Select Committee on Infectious Diseases and High-Risk Disadvantaged Communities. My name is Mike Gibson. I chair this committee, and also I'm the chair of the Assembly Democratic Caucus. This informational hearing is the fourth in a series that has taken place throughout the entire state of California, so that we can better understand the impact the HIV and AIDS have on our community here in California. I want to thank the County of San Bernardino for all of your support. They have been gracious to provide the space, coordinate logistics, and also provide refreshments, as well as become an active partner in the development of the contents of today's hearing. So I want to personally thank the County of San Bernardino for your commitment and also your partnership. Now with us, I would like to invite to give us an official welcome Supervisor James Ramos, the 3rd District here in the County of San Bernardino, who will give us our official welcome. Thank you very much.
Thank you, Mr. Chair. So I'd like to welcome you on behalf of San Bernardino County, on behalf of the Board of Supervisors. And this topic is something that's true and dear to our hearts here in San Bernardino County on infectious diseases in all communities that's faced. And we thank Chairman Gibson for assembling this hearing and really going throughout the state and picking up all the different information that's there that would lead to hopefully getting things to those that need those support services that are there. Also, I'd like to recognize Assembly Member Alois Reyes here also. And together, this panel and the Mr. Chairman moving forward on these issues brings to light a lot of the issues that face all of our communities that we look forward to partnering with you here in San Bernardino County. So on behalf of San Bernardino County Board of Supervisors, welcome to our chambers, and thank you for taking up this needed cause.
Thank you very much. We appreciate your leadership in this area and you being here, taking time out of your busy schedule, and also the commitment that the county has in terms of working with the state to eradicate and to get to 0 new infectious cases, not only in San Bernardino, but also in the state of California. So can you please give our supervisor a great big round of applause for being here and his support and his staff. Thank you very much. Thank you. So let me just get right into it. Today's hearing specifically will focus on the disparities in access to care within key populations across different regions in this state. New scientific innovation continues to disrupt the high rate of infectious disease associated with HIV and AIDS. Previous hearings have focused on some of the research such as PrEP and PEP and its impact in helping to eliminate new infections, especially in high-risk, disadvantaged communities. Our focus today is on the structural barriers that makes it difficult to eliminate new HIV infections and to help those living with HIV access to vital services that are desperately needed in our community. Both of these goals are centrally and currently focus of this particular committee, the Select Committee, in high-risk disadvantaged communities. It is our goal as well as our vision to get to 0 new infectious cases, get to 0 deaths, 0 stigmas against those living with HIV and AIDS. Getting to 0 is only possible by taking a collaborative and comprehensive approach in identifying communities who have by far been underrepresented or left out of the conversation and the discussion around HIV and AIDS. In that spirit, this hearing will begin to discuss the current state of HIV. Before transitioning to this discussion, we will talk about the disparities among the key populations here in California, but specifically here in San Bernardino as well. Experts in the public health and HIV services will also speak to the gaps in services delivering through the region and various areas within our communities that are being challenged by the lack of resources. We will also have a 2-part panel discussion that is devoted to this discussion that will talk about the policies of implementation and also topics where we will get deep down into the examination of the issues that's facing our community. I want to thank you all and the panel in advance for making yourselves available today, and also for all of you, the public, for being here to be part of this very important discussion. The audience will also play a very key role towards the end. And so we would certainly ask you to write down your questions and anything that may be on your mind in this area. We will make available for you the monitors and the podiums for you to be able to ask questions of various members on the panel. So you will play a very key role because we want to hear from you. We want to hear from you in terms of what you see, what you feel that we should be doing. And it's my goal to be able to take this information back, share it, and also document it as we will do today, but also making sure that this input that you will provide today will be chronicled and in a white paper that we will submit to the legislature for its adoption. Many of you may or may not know that California, although as progressive as we are, we do not have a white paper. Other states such as New York and Chicago and Denver, other states have a white paper on this particular issue, but as progressive as California is, we do not. The White House under the Obama administration came out in 2005 with the white paper, and you would think that California would have come out and followed that. And so that's the mission, that's the goal. So we'll have a roadmap in terms of where we need to go, and also making sure where services and also resources need to be placed to eradicate and to get to 0 new infectious cases in this state. If there's any elected officials, we would love to recognize you. If you could please pass up your business card so we can recognize you in our program in this hearing. And again, we thank you in advance for being here. I want to pause for a moment and also recognize my colleague, Ms. Reyes, who represents this particular area, who's provided great leadership in the legislature. We want to pause for a moment, give her opportunity to welcome, introduce herself, and also any other comments that she may have. So please help me welcome Assemblywoman Eloise Reyes.
Thank you. Thank you so much, and good afternoon. As the Assembly member here for the 47th Assembly District, I do want to welcome you all here to San Bernardino. Special thanks, however, to my colleague, Assemblymember Mike Gibson, for hosting this particular hearing here in San Bernardino. He is the chair, as you all know, of the Assembly Select Committee on Infectious Diseases in High-Risk Disadvantaged Communities. It's really important having this particular hearing here in our community. To all of our speakers this afternoon, thank you for making time to be here with us. It's crucial that we all come together on this important issue. As you may know, or you will know shortly, there are approximately 140,000 Californians living with HIV, and there have been over 100,000 Californians with HIV who have died since the beginning of this epidemic, according to the California Department of Public Health. There remains a need to raise awareness and improve HIV knowledge in the general population of California, and most importantly, in our disadvantaged communities, including here at the 47th Assembly District. According to the San Bernardino County Department of Public Health, San Bernardino County alone has an estimated 3,500 people who are living with HIV here in San Bernardino County. They also report that 200 new HIV and 100 new AIDS cases are reported each year in our county. We must work together as a state to find ways to provide meaningful HIV prevention measures, both to prevent new HIV infections and to reduce the stigma of HIV. I applaud my colleague, Assemblymember Gibson, for holding this public hearing here in San Bernardino. I look forward to the discussions that will follow. This is such an important topic that we need to focus on. I also want to give a special recognition, acknowledgement to my dear friend, Gabe Maldonado, founder and CEO of True Evolution, and our public health experts who are doing such amazing work on this topic here in the Inland Empire. I thank you for joining us here and providing your assistance to this very important conference, this very important hearing. If I personally can be of any assistance to any of you, please don't hesitate to reach out to us. Thank you.
Thank you very much. Well, let's get right into it. And we'd like to introduce Mr. Gabriel Maldonado, the Executive Director and CEO of True Evolution, an organization dedicated to providing prevention and eliminate HIV. Mr. Maldonado will be serving as our moderator today. Would you please stand so we can recognize you? Let's give him a round of applause, shall we? Thank you very much. Now to begin, I would like to currently invite our panel up to the podium, to the microphone, to please take your places. Each panelist will have 15 minutes to speak and will present in the order noted on the agenda. Before the presentations, please introduce yourself. After all the panel has finished, members will be invited to ask questions at that particular time. After you finish your presentation, we will engage in a brief dialogue. So at that time, please.
Thank you. And actually, Kim Woods and myself, we combined our presentation into one so that it's a co-presented.
I don't know if that microphone is on. Can you hear him okay?
No. Is this one on?
Oh, let's try this. Oh, now does it work? Okay. That was good.
Because that's what people need is my voice amplified. Yeah, okay. And so we wanted to present really just a brief overview of some of the broad strokes of the HIV epidemic within the two counties, Riverside and San Bernardino. We are Aaron Gardner and Kim Woods. And some of the some of the terminology that you may hear through our presentation and throughout the day, we like to revisit for our folks. And one is prevalence, which refers to people living with HIV disease, regardless of the time of infection. Incidence, which is newly diagnosed cases of HIV or AIDS during any specific time period. And then rate. Rates are something that epidemiologists use. We convert numbers into rates to be able to look at the burden of disease across uneven populations. And by uneven, we mean like the population size. So for example, the Hispanic population in Inland Empire is much larger than the African American population, but we want to be able to compare the relative burden of disease. And so we convert things to rates for that. And then the service areas for the 2 counties, the Ryan White service areas is divided into 6 planning regions, which we use, and we have a map for that. And so here's the service area map for the Inland Empire. And the Inland Empire is actually 27,000 square feet. And the, oh, did I say square feet? Yeah, square miles, sorry. It's a very large house. No, it's 27,000 square miles. It's 4.5 million people, which has a population that's larger than 25 states in the United States. So it's a large and challenging geography for us to reach. So prevalence, or those living with HIV, in the 2 counties is nearly 12,500 people. And then that's 8,400 for Riverside County and about 4,000 for San Bernardino County currently. This is the proportion of the population, and then the proportions of those living with HIV and those living with AIDS for the 2 counties combined. And here the blue bars are the general population, or the proportion, and so really for this, anywhere where the red and green bars are higher than the blue one is an area where that population is being disproportionately impacted or disproportionately affected by the disease. And here we see that for the 2 counties, whites, primarily that's Riverside County, and then African Americans are disproportionately impacted. And then here's prevalence, again, that's people living with HIV by rates. And here, again, we see that whites and African Americans are particularly impacted. And actually for the 2 counties, the Hispanics are actually, the rate is lower than we might expect given the size of the population for these 2 counties. And then this is prevalence by service area, if you recall the map that I showed earlier. And here this shows some of the larger differences, at least certainly by race or ethnicity for the 2 counties, where Riverside County has a much larger white people living with HIV, and San Bernardino County a much larger African American and Hispanic population living with HIV. And then this is AIDS incident rates, or new cases of AIDS, so people who had HIV and then got a diagnosis of AIDS over time. And we see that AIDS incidence rates are going down in the 2 counties over time, but and in fact, whites and Hispanics have about matched, but African Americans are still disproportionately impacted throughout the 2 counties by AIDS. And HIV incidents, or brand new cases of HIV, we see that for all populations, actually it's been ticking upwards over time. And whether or not that's improved testing, so more people getting tested, or actual new cases of HIV is hard for us to tell, but we just know that there are more diagnoses of HIV. And again, African Americans in the 2 counties are disproportionately impacted. And then this is persons living with HIV or AIDS, a little bit about by age. Here we have people living with HIV or AIDS at the time of their diagnosis, or the time that it was reported to us, versus the age now. And what this shows is the aging population of people living with HIV throughout the 2 counties. And the population is getting older, where primarily it's people between 25 and 44 who are diagnosed with HIV in the 2 counties, though it is slightly younger in San Bernardino County and older in Riverside County. But then over time, you know, it's primarily then those people 45 and above as they age now. And then these are risk factors for HIV for cases between 2014 and 2016. And here we see that it's 65% of the all reported HIV cases during that time period are from unsafe sex among gay, bisexual, or other men who have sex with men. Really followed by unsafe sex among heterosexuals at about 7% with the two counties combined. Risk unknown or other, that's just that we weren't able to identify a particular risk factor for that person at the time. Oh, and do you have anything else you wanted to add
I was just
for
going to
that
say
section?
that between the two counties, thank you. I think this one worked. San Bernardino is slightly different than Riverside in that we have more heterosexual transmission and more transmission among our intravenous drug users. Yeah. Okay. Well, another marker of burden of HIV is how people are doing when they're in care or not in care. And this is the continuum care for California, Riverside, and San Bernardino counties. The first group of columns is people that are in care, and you can see that Riverside is slightly above California and San Bernardino is slightly below California in terms of the percent, and obviously we want those percents to go a lot higher. And they define in care by people who had at least one CD4, a viral load, or an HIV genotype test. The second group of columns is the people that were retained in care. And as you can see, we're right at the 50% mark for all of us. And Riverside is just a little bit below California, and we're below where we want to be, below both in San Bernardino. And retaining care is at least two CD4s, viral loads, or HIV-1 genotypes at least 3 months apart in the year. Virally suppressed is probably one of the more important measures, and that's folks that were had a viral load less than 200 in their at their last test. California is at 56%, Riverside's at almost 59%, and San Bernardino comes in at 47% and a little bit more. Let's see here. The next step then is to look at the people who don't have viral suppression, and by gender in California, we see that the lowest amount of viral suppression is among two populations, among our transgendered folks, the male to female and female to male. By race ethnicity, we see again that our African American folks have the lowest viral suppressions, followed by slightly higher at our Hispanic population. By risk group, our injection drug users have the lowest viral suppression, and followed by our male heterosexual high-risk group. And of course, viral suppression in general is very important because of the decreased risk of health effects in people that are suppressed, and then the decreased risk of transmission to other human beings. CDC has recently announced their new campaign, U equals U, undetectable equals untransmissible. And then by age group, we have some work to do in the 13 to 24-year-old range in California. They're at the lowest at 44%. And the 25 to 44 is at 51%, and they account for about 30% of all the people living with HIV/AIDS, at least in our TGA. Another way of looking at the burden some of our populations have is is thinking about who's at risk for HIV also. And these are three different, by age group and gender, these are three different infections that are very similar. The top one is gonorrhea, middle one is early syphilis, and the bottom one is HIV/AIDS. And as you can see, if the blue is female and the orange is male, and you can see very similar sizes in the shapes of the columns and where the highest numbers are, or the highest rates are. There's a lot of overlap in STDs and HIV, and as a result, HIV data and STD data and their overlap is getting a lot of attention. We know that the presence of an STD increases a person's risk of HIV 2 to 3 times at least. And then we also know that, especially with gonorrhea and syphilis, a lot of our STD, a lot of those cases are also co-infected with HIV. And we see similar shapes of the columns by race, ethnicity, and gender also. And again, we see some of the higher columns among our African American population. So to that end, the HIV STD programs, in doing investigations and things like that, they will ask if there was an HIV test for our folks with syphilis, and if the person is positive, they will ask if the person is in care. So for folks that are HIV positive also, the goal is to get them linked into care. For STD cases that are not HIV positive, the goal is to offer them PrEP, if that's appropriate for them. Okay. Syphilis is a huge issue for both counties. As you can tell, it's on its way up, and then at the bottom, this is a slide that the STD branch did a couple of weeks ago at a huge HIV conference. And as you can tell, our males who have sex, our gay and bisexual males, made up 72% of our male cases. And of those, 55% were also infected with HIV. We know that 1 out of every 18 gay and bisexual males who have syphilis will come down with HIV in 1 year. That's the stats. Without that risk of syphilis, it's something like 1 out of 53. And then, as you can tell also, one of the things going on, this is especially true in San Bernardino, is the number of females with syphilis has doubled. So then we're talking about risk of HIV higher risk among some populations. As you can tell, and this is from CDC, that our African American males face very high risks of HIV a lifetime, and all the way the disparity in the risk of lifetime of HIV is very high. It's very large.
And then both Kim and I understand when we start throwing around rates and percentages, slide after slide, how people start to glaze over a little bit. We're both, as epidemiologists, we're well aware of what we do to people with our slides. So we do have some summaries that I think help bring home some of what the data slide showed, and that's again, there's at least 12,435 persons living with HIV or AIDS in Riverside and San Bernardino counties. Nearly 30% of new HIV diagnoses are among those 45 years old or older in the two counties. The rate per 100,000 of new HIV diagnosis among African Americans is double that of white or Hispanic residents in the two counties. Since 2007, the HIV diagnosis rate for Hispanic residents has increased 55%, though, and this is something that we need to keep an eye on. There we go. Nearly a quarter of all new HIV cases are from eastern Riverside County. That's basically Palm Springs to Blythe of Riverside County. But this is mostly the Palm Springs, Coachella Valley region. 44% of all new HIV diagnoses are in San Bernardino County. 44% of all persons living with HIV are in eastern Riverside County. And then some of the racial ethnic differences between the two counties. 72% of San Bernardino County persons living with HIV are persons of color versus 37% for Riverside County. It's very different. And in 2016, nearly 44% of new syphilis cases in Riverside County were co-infected with HIV, compared to about 25% in San Bernardino County.
And then another bullet that we probably could have added too is we have proportionally we have a lot more females among our cases also.
That's it. And sir, if there are any questions about the data?
With a presentation like that, there's a lot of damn questions. Let me just start. How has California fared in the rate of new infections, and the rate of viral suppression compared to the national trend?
You know?
I don't have
I don't have the national stats, neither of us do before us, but I think California's comparable to the national stats, not necessarily particularly better, but not particularly worse either with it. We still have a lot of work to do.
Sure. Two additional questions, or maybe three, I don't know. But do you think that PrEP and PEP is assisting based on the numbers of your presentation?
I don't know if Kim can answer. I know for me, yeah, I'm not the best person, but some of your other panelists coming up, okay, who work, in the field with the clients, will be able to answer that question better, I think.
Sounds good. Yeah. My next question is, with the number of African Americans, because I've been tracking this for a long time, still leading, not only in California, but you look at the national numbers, still leading. What do you think is needed to address this from California's perspective? Is that another panel? We can wait for them too.
I think so. I mean, again, we have, we have experts here in the room who can address that, but I think it's just continue with, more aggressive outreach and testing, and we, in a lot of ways, we've been doing a lot of things the same way for a long time, and so there's some space there for some innovation in being able to reach this population that clearly we're not reaching.
Ms. Reyes, would you like to chime in?
Yeah. I did want to ask, I know that when it comes to funding on grant applications, you're looking at newly diagnosed. And I know that sometimes people are diagnosed, they may go, they're better services, say in Los Angeles, so they will go there to be tested. They now are counted as being diagnosed in Los Angeles, but they really live in San Bernardino County. Is there a way to track this so that the services and the money comes to San Bernardino County rather than it being siphoned off to Los Angeles, where it was just the diagnosis, not where they're living?
Well, we do report people by where they live at the time of their diagnosis. And over time, the last couple of years, we've gotten much, much better too at figuring out where people live in relation to where they get care. But we do report both HIV and AIDS by where they're living at the time of their diagnosis. There's new variables coming out this year that will help us understand who actually is living in the county and getting care. And because we know there's a lot of migration.
If I may, and I think beyond just migration, the fact that many of those living in San Bernardino County don't have the access, except for organizations like True Evolution that can really help our population. Many of them leave so that they can be properly diagnosed, but then they come right back. So they're not migrating to San Bernardino, they live here, but they're trying to get the proper diagnosis and know what the services are, but they really live here, and we want to be sure that the services, or the funding for the services, are provided here.
We do. San Bernardino in particular has a lot of high-risk individuals, and we do also, the public health department also has an enormous HIV clinic. But you're right.
I think in partnership with the California State Department, Office of AIDS in the California Department of Public Health, along with us, we've been receiving not only new variables, but the being able to attribute patients to where they live now, as opposed to necessarily where they were tested and things like that, have been improving a lot, particularly over just the last 6 months or so. So recent that Kim and I haven't even been able to completely explore all of those numbers yet. But there's been a lot of improvement in us being able to track that, which then we can give these new numbers not only to our own agencies, but to all of our partners here for increased funding and to make those arguments for better funding.
I appreciate that. Thank you.
Well, thank you very much. I appreciate your presentation. We'll invite up next our next panel. Now let me welcome the next panel who will speak in the area of health disparity among key populations. Would you please come up and take a seat? We'll give you 10 minutes to introduce yourselves and also go right into your presentation.
Good afternoon. My name is Erica Washington, and I'm coming to you from AIDS Healthcare Foundation. Thank you for the opportunity to speak on behalf of AIDS Healthcare Foundation, and more importantly, to lend a voice as an advocate on behalf of the homeless population in Riverside and San Bernardino counties. I'm going to speak to you today on homelessness as a comorbidity. And so I'll begin by giving a little background information on the relationship between homelessness and HIV. Homelessness and HIV are very closely related. As a case manager, I have witnessed homelessness leading to an HIV diagnosis, as well as an HIV diagnosis, factors relating to and events leading up after a diagnosis leading to homelessness, lost jobs and such. I have also seen that our homeless clients are very much more likely to be diagnosed with HIV and AIDS, and also other chronic conditions such as diabetes and heart disease in addition to HIV. Additionally, our homeless population deals a lot with mental health and substance abuse disorders, and several of our clients are addicted to meth and other injectable IV drugs. I've in particular worked with a client who, one second. Bear with me. I've in particular worked with a client who was addicted to meth, and had a very difficult time dealing with both substance abuse and mental illness, trying to receive services from us. So that leads into poverty, substance abuse, and mental illness, and how it relates to homelessness. Homeless persons are in transient living situations, typically in impoverished communities with high HIV prevalence. Thus, risky behaviors they may engage in are more likely to result in infection. So, conditions of homelessness and extreme poverty also contribute to risky behaviors because our homeless population are living in communal sleeping areas, they're sharing communal bathing areas. A lot of our shelters are single sex and offer limited privacy, making it very difficult for our homeless population to maintain very stable sexual relationships. Once again, meth addiction is very common among my clients. Many of them are really not even willing to go into a shelter because when they're dealing with addiction and mental illness, there is increased vulnerability for them to survive in some of the conditions that we have in some of the homeless shelters. We want to make sure that we're not putting so much emphasis on viewing them as lazy or dangerous, criminal, or insane or unwilling to work, because the truth is a lot of our population, when dealing with these compelling situations, are simply unable to function in society as we might expect them to be able to. Substance abuse among the homeless can worsen the symptoms of mental illness, driving an individual deeper into the cycle of poverty, homelessness, and despair, according to American Addiction Centers. More on the conditions that our HIV-positive homeless population experience on the streets and in shelters. Homeless people with HIV and AIDS encounter many challenges to their health due to factors such as poor hygiene, malnutrition, and exposure to the cold and rainy weather. Homeless people are 3 to 6 times more likely than housed people to become ill. In addition to HIV, they are struggling to maintain their immune system already, so they have a lesser ability to fight off these diseases, which makes their risk even higher of other illnesses. Availability of permanent housing is essential to helping this population. To address housing needs for low-income persons who are living with HIV and AIDS, their families, the Office of HIV and AIDS Housing manages the HOPWA program, which is the Housing Opportunities for Persons with AIDS. Although this program is working and provides an awesome opportunity for HIV-positive clients to have permanent housing, there is currently a significant wait list in both San Bernardino and Riverside counties as the programs are operating at capacity. I was able to get some exact numbers on these wait lists. In San Bernardino County, the wait list is 85 as of 12/12/17. In Riverside County, the wait list was 98 as of 12/12/17. And the Section 8 wait list for Riverside County is approximately 68,000 families long as of 12/15/17. So these numbers mean that the wait time could be years before our clients are placed into the housing that they are needing. Moving on to the importance of case management in serving this population. According to our standards of care at AIDS Healthcare Foundation, the goal of case management, non-medical, is to assist individuals in attaining and maintaining a maximum level of health and independent functioning through the coordination of resources. Medical case management, the case manager's goal is to successfully implement a collaborative process of assessment, planning, facilitation, and advocacy for options and services to meet the needs of the clients. As a case manager, we engage the client and build trust to start. Then we assess the needs of the client. We work with the client to create a care plan and to address the need, which in this case would be homelessness and possibly mental illness and substance abuse in addition. We focus on walking them through the process as far as contacting a housing case manager, a dual diagnosis treatment facility, or other needed services, and we monitor their progress and their need for additional assistance. it's very important that we work closely with housing case managers in the field at agencies such as Foothill AIDS Project and True Evolution to meet the needs of clients who are homeless or at risk of becoming homeless. Housing case managers provide an in-depth knowledge of the available housing resources and assist the client in development and implementation of a plan to achieve housing permanency. I'll give you a specific example of a client that I've worked with personally. He was living in a vehicle in someone's backyard, experiencing severe malnutrition, very weak and unable to walk long distances without assistance. He did not have any transportation in order to attend twice monthly medical and follow-up appointments that would be necessary in order for him to receive some of the more specialized medications that he needed. SSDI was his only income and is not able to cover all of his monthly expenses. When I encounter a case like this as a case manager, the goal is to ensure that the client is able to have some type of supportive and transitional housing in between the emergency housing that is offered at agencies like True Evolution and the long-term supportive housing that they are able to obtain through organizations like Section 8 in the HOPWA program, which could take years. In conclusion, the experience of homelessness exacerbates the disease and hinders treatment. According to research, formerly homeless people were 4 times more likely to get medical care once they had been placed in supportive housing than when they were in case management alone. Housing also increases the likelihood of receiving and adhering to ARTs. More funding needs to be allocated to providing people living with AIDS and HIV with supportive housing. Thank you.
Thank you very much. Very thorough presentation. Thank you. Yes. Next, we want to invite our next panelists up who will deal with recidivism. From the Foothill AIDS Project, would you please come and take a seat? Feel free to introduce yourself, and you can commence with your presentation.
Good afternoon. I'm Jenny Richardson, and I work with Foothill AIDS Project. I am currently substance abuse, formerly AB 109 house manager, counselor, mother, everything behind it.
Hello. Okay. And I'm Anthony Brazier. Excuse me. I'm the housing coordinator for Foothill AIDS Project, and I oversee our housing department, Riverside and San Bernardino. And we have been working with our incarcerated population for the past 6 years. And Jenny was one of the staff that helped me start the project, and she'll be here to talk about recidivism, as well as talk about some of the things that we've seen within our own agency in terms of our incarcerated population. So I'm going to hand it over. We don't have a PowerPoint, but I think it'll be just as...
We can dance.
Yeah.
Again, my name is Jenny Richardson. In 2012, we got a grant for the reentry program to house people who have HIV, specifically for HIV in the beginning. And these were for people coming out of jail who were nonviolent offenders and did not need to be on parole. They could be on probation. So we worked directly with probation. Anthony and I worked with the AB 109 probation officers and all the people involved there to make the rules and regulations and how everything would work. We got our first client, and I won't mention any names, but he came to us and he lasted about 2 months because he was caught up in the lifestyle. He shortly after that went right back to prison. He got out again and came and applied again and again and again. And that's what it's been like. We went on to, I think in the second year, we added non-HIV clients to help supplement, so we didn't lose the grant, first of all. We could use the money for more things, and that was in building a whole new program. We got more help from outside at that point. People came in and hooked our guys up with doctors and so on and so forth. We got everybody tested on a voluntary basis. I had a stick behind me, but no. They, on a voluntary basis, were able to get not just tested for HIV, but for STDs and also for hepatitis C. We did a housing program. One of the first things when somebody comes out of jail, especially if they're disenfranchised from their family or anything like that, is they want to know where they're going to lay their head that night. They want to know, some of the guys that came from long distance from the prisons up north and so on, we were able to provide a hotel for a couple of days. That was not a great idea, so we worked on it more and continued to get people. So when they came out, we had somewhere for them to be placed the day they were released, once they checked in with probation. It's been kind of like a trial and error thing with it. But the second thing they worry about when they get out is where they're going to get something to eat. They're not released with anything. It used to be released with gate money when they came from prison, but they don't do that most of the time anymore. It goes straight to the parole officer and they have to go pick it up. If they've had family in the area and they're gone now, they have nowhere to go. If they come from a domestic violence situation where one of the spouses is in prison for that and then wants to come back home, most of the time he has a restraining order, so he can't. All of this disturbs the continuum of care for somebody who's been in prison or incarcerated in one of the jails for a long time. They're set up with 1 month's medications, then they get out here and they got to figure out where they're going to sleep, where they're going to eat, where they're going to bathe, all of those things. The last thing on their mind is going to public health to get medication. They just need to know where they're going to be. So that's one of the reasons they go back. That's one of the reasons they recidivate. They know where they're safe, they know they'll get medication, they know they'll have, as they say, 3 hots and a cot every night to be able to go back to, and so it's very easy to do that. If you are going back to family that no longer wants you there, the number one reason, just let me cut all this short, the number one reason for people to go back to prison and or jail is homelessness. They have multiple barriers when they get out of being incarcerated. They may have been infected while in jail. If there's one person in jail who is not, or is tested and is positive, then that person affects other people. And if a person is in there for approximately 6 months, they're an active sex worker, and they just transfer that into what they're doing in prison, then they can infect up to 200 other people. And then you have our population blow up with HIV people one more time. Some of the suggestions I would have would be more education. When they are incarcerated, I know they are not promoting sex in any way, shape, or form, but if they handed out with some harm reduction in mind, condoms for the men's jails, that would slow something down. Other things that would...
I'm sorry, let me interrupt. Normally I don't do that, but I want to ask this question since you made mention of that. Do you believe in mandatory testing? There was a bill some years ago, I think it was authored by Senator Mitchell when she was in the Assembly, about mandatory testing while incarcerated. Is that something that you have an ideal?
I want to say yes, but again, then it violates all rights as well. At Glen Helen, I go there for the monthly or the quarterly meetings, and what they do is offer. And then they have people like us come in and talk to people about this. And the rate of people being tested while incarcerated has gone up. They can get tested for STDs, you start with teaching, because as soon as somebody hears HIV, they just, come a little unhinged. So you say, well, what about STDs? I know you have sex, so you need to get tested for these things. And then HIV, you might as well. It's not going to hurt. It's getting done at the same time. And then hepatitis C that kills 5 times as many people as HIV does. So they're working on it. That's just one jail that I've been to that they do that at. But they don't pass out condoms either, though. But I think that the right should be to choose. However, maybe if it was a person who was arrested multiple times for sex work, maybe they should be tested.
And I would like to also contribute to that, because I think for San Bernardino Riverside, Right now, there are models in Los Angeles in which there are a few agencies like Tarzana, Minority AIDS Project, other particular agencies that actually are in the jails on a very consistent basis. And that could be another way of maybe not mandating testing, but having that continuum exposure inside the jail as part of their educational piece and one-on-one discussions about sex and sexuality and issues would even raise the testing, folks wanting to get tested more often. So mandatory is kind of difficult, but engagement is probably best. And how do we engage that population? And that might be some of the models we can use in San Bernardino and Riverside.
If you tell anybody on their way to jail that they're going to have to mandatory do anything, of course they're going to bucket the issue. But when you present it in an education forum, there are usually 20 to 25 vendors at Glen Helen for all different kind of things. So they're learning about everything. It's not just that singled out. It is kind of, you know, HIV is, as everyone in this room well knows, is still a taboo word to people. People are still ignorant of no education about what it is or how you can catch it or anything like that. So, but if you put it in a group of people and make it an open forum, or this person might want to go talk to you separately for a minute. And I've had that. Someone lean over the table and ask me a couple questions about it. And the next time I go, they're still there and they've gotten tested. It's just like, you know, if one gets tested more than none, then it's better.
So no mandatory testing, but education that includes condoms in jail, prison.
But also engagement. So what
Right.
does that look like in the jails? Because I think even just offering condoms, even just offering testing, but engaging those folks as not just while they are incarcerated, but looking into issues before they got there and engaging them in those kinds of conversations. And like Jenny discussed, the other issue when it comes to our incarcerated population in terms of recidivism is also mental health.
Right.
So when you entangle all of that and their unresolved substance abuse issues, returning to jail, from our perspective and our experience with our clients coming to our office, those are the things we see. But I really just put an engagement.
Thank you. Just one final question. What can the state do better in this area?
Educate while incarcerated.
Okay.
Pre-incarceration, post-incarceration, health fairs, all of that kind of stuff. Education, just put it out there.
And I think for me is looking at, well, taking all the folks who are on the front line and developing a strategic plan. I know this is another meeting, but I really think for us, it is that partnership between those folks who work in jail and those of us who serve that community when they get released. And I think that collaboration needs to be tightened up, because right now, we're all doing awesome work, but we're sort of missing each other. And where can we get together to sort of better partner, collaborate with the engagement, with the release process, with their medical services, et cetera?
Sure. I'm going to challenge you. This is unorthodox, but I'm going to do it anyway because I'm the chair. I want you to correspond with me on some of your ideals, because you are the practitioners, the experts in this area. I want to really vet some of your ideals out and share it through public policy, through our Ledge Council, and see what we can come up with. So if you can please do that within the next 20 days. We go back to Sacramento January 3rd. I would love to have that before then. If you would do that for me, I would greatly appreciate it.
And not a problem. And Dr. O reminded us that San Bernardino has a reentry program. And I've been sitting at the table, being a part of that, because we are addressing it as a bigger population. I think for this specific population, HIV, as a broader, the reentry group is doing an awesome job in terms of those release process and helping those clients to get released. And I've been at the table trying to help with the support of that population getting released. So definitely, we will welcome that opportunity, and we will definitely be working with Dr. O to develop that and sort of give you some tools.
Well, I thank you very much. If you can see Mr. Ibarra. Mr. Ibarra, would you please raise your hand and exchange contact information so that I can follow up with you. You can follow up with me.
Thank you.
And I thank you very much for your presentation.
Thank you.
Thank you. Let's give him a round of applause. Thank you. Next, women, we would like to call up Planned Parenthood. We have a representative. Thank you very much.
Good
Jacqueline, for being
afternoon.
here.
Hello. I think I do have a PowerPoint. I wonder if it's going to come on.
Do we have a technician?
Oh, do I? Oh, fantastic. Thank you. Good afternoon. Thank you so much for holding this hearing and for inviting us to participate. I'm Jacqueline Casillas. I'm with Planned Parenthood of the Pacific Southwest. Our partner, our colleagues with Planned Parenthood of Orange and San Bernardino County could not make it, so we're stepping in and helping out. We're in the neighboring county of Riverside. Pacific Southwest actually covers Riverside County, Imperial County, and San Diego County. And our mission is to ensure broad public access to reproductive health care through direct service, education, and advocacy. Folks often think of us as, and rightfully so, as a healthcare provider first and foremost, but we also provide education and advocacy work in our affiliate. And although not listed here, our vision is grandiose, but we're going to get there. Our vision is for a world where sexual and reproductive rights are basic human rights, where access to healthcare doesn't depend on who you are or where you live, and where every person has the opportunity to choose their own path to a healthy and meaningful life. So we work towards that mission and vision in everything we do. And so I want to start off by giving you all an overview, well, that's really what I'm here for today, of our affiliate has 16 health centers. We have 11 health centers in San Diego County, 4 health centers in Riverside County, and 1 in El Centro. We provide a range of services, of medical services, and here they are listed. We have, birth control, STI, UTI testing and treatment, abortion care, prenatal and adoption referrals, permanent contraception, men's health. And included in these services are PEP and PrEP. And I would like to share our 2016 figures for HIV testing and positivity rates at our Riverside health centers. Although not listed here, I'm going to share the numbers with you. So at our Coachella Health Center in 2016, we provided 2,351 HIV tests. And at the Coachella Health Center in 2016, 16 of those were positive HIV. At our Moreno Valley Health Center, we provided 5,789 tests, and 73 of our patients came back positive. In Rancho Mirage, we provided 2,474 tests, and 31 of our patients came back positive. And in Riverside, we provided 4,814 tests, and 67 of our patients came back HIV positive. So that means in 2016, we had a total of 187 positive HIV tests. We conducted we provided 15,428 tests. So Planned Parenthood really prides itself in keeping our doors open and not turning anyone away. We provide a lot of options for our patients. We do everything that we can to provide care, and so there's all sorts of different payment options. A lot of our patients rely heavily on family pack and Medi-Cal services, and if they do need to provide payment in cash, we have a sliding scale. We really try to meet folks where they are and not turn anyone away. Family pack, which I'm sure you're familiar with, there's guidelines, and we work closely with our patients to make sure that everyone who qualifies can access it. Here are some stats of our medical visits in 2016, our fiscal year. As you can see, our total visits were 277,847 in just our 3-county region. The vast majority of those visits were for contraception and STI tests. Then we have a smaller quantity of those were for pregnancy tests, abortion services, and cancer screenings. So a vast majority of our patients really come in because they just want to stay healthy. It's preventative care, and they just need the basic tools to live a healthy and productive life. For many of our patients who come in and receive these services, they often say that the visit that they receive at Planned Parenthood, it will be the one doctor's visit that they receive in their entire year. Some demographics are that we are very trusted by women. We provide care for everyone. However, 87% of our patients are identified as women, and 13% of our patients identify as male, and less than 1% identify as gender nonconforming or transgender or something other than. And then, so one of the largest statistics too, and this is true for all Planned Parenthoods across the nation, is that 1 in 5 women come to Planned Parenthood for care, for confidential, non-judgmental care. And so our patients, and this is just, it kind of came with, you know, the mission and why when we were first founded, women come to Planned Parenthood because we don't turn them away, we provide the care that they need and don't second guess what they want or need. They are the, you know, the advocates for their health, and we trust them as experts. A few more demographics, and this is by age. We've got 42% of our patients are between the ages of 18 and 24, and that's the largest proportion. And then that's kind of shrinking. This used to be the age where children were aged out of their parents' insurance and before they could get insurance through their work. But even with the ACA, it's still the largest proportion of our patients. Second largest between the ages of 25 and 29. So that's the healthcare portion of Planned Parenthood. The 2 last prongs of our mission, which are providing and ensuring broad reproductive health care access, is through education and advocacy, and that's taken care of by our Community and Government Relations Department. We have community educators that go out to schools, to foster homes, to I'm blanking on the other locations, but we're literally, our educators are everywhere. Anywhere that someone wants to learn about how to take care of themselves, we're there. And we provide courses on, STIs, healthy relationships, anatomy, we provide courses to our parents on how to talk to their children about reproductive health. And then the third component is public affairs, and that's where I actually work, and that's we'll work on the advocacy piece and the legislative and policy changes that are necessary to ensure that this kind of work can continue to be done, to ensure that our health centers' doors stay open. And so that is Planned Parenthood and the services that we provide to women in our community. Thank you.
Well, thank you very much for your presentation. Thank you. Next, we'll have another panel up. I'm dealing with the undocumented communities. AIDS Healthcare Foundation. Great, and welcome.
Thank you. Thank you. My name is Susan Cho. I'm a medical case manager with an AHF. It is my privilege to present such a big topic on HIV and undocumented persons. Starting off briefly with the history of the HIV positive immigrants, U.S. experience, and U.S. policy, HIV-related restrictions for those visiting or immigrating to a country exacerbate these problems by breaking families apart, dividing spouses, separating parents from their children, limiting employment and educational opportunities for people with HIV, and discouraging individuals from seeking testing or treatment for fear of being denied entry or placed on deportation proceedings. Prior to 2010, federal immigration law prohibited people with HIV from entering the country. The U.S. recently, which is January 4, 2010, they removed statutory and regulatory bans prohibiting people living with HIV from entering the country, according to HIV law and policy dated 2017. Despite changes on policy, fear of deportation is still very real for undocumented clients seeking HIV health care in U.S. Speaking of current situation, kind of focusing on Mexican immigrants, there are an estimated 3 to 6 million Mexican undocumented residents in the U.S., and most of them live in California and Texas. The largest percentage of undocumented persons live in the state of California. In California, more than 1 in 4 residents, which comprises of 27%, are foreign-born. Currently, 1 in every 10 Los Angeles County resident is an undocumented immigrant, and many of those immigrants have been in the U.S. for more than a decade and are the parents of children who are American citizens. In the heading talking about access to health care, the vast majority of undocumented immigrants are less likely to have health insurance and more likely to prolong visits to any clinic, doctor, or hospital due to the lack of information, financial resources, and access to health insurance. According to a website called healthcare.gov, undocumented immigrants aren't eligible to buy marketplace health coverage. Program at AIDS Healthcare Foundation, Ryan White program provides assistance as a payer of least resort for HIV healthcare services. At AIDS Healthcare Foundation, undocumented clients are encouraged to seek the immigration assistance of an attorney who works with underserved population in order to become lawfully present and obtain ability to apply for health insurance. Some of the facts of undocumented immigrants are unique in that unless they find employer-sponsored insurance or live within a limited number of regions with non-federal public insurance programs that are open to all low-income residents. In regards to HIV health care for undocumented people, state funds can be utilized in addition to very limited federal funding called Ryan White program. Barriers faced by HIV-positive undocumented persons seeking to obtain permanent residency. Persons seeking citizenship or naturalization and who did not enter the U.S. legally must leave the country for medical testing in some cases. In some cases, if a person did not enter the U.S. legally or have lived in the U.S. illegally more than 180 days, they may be subject to re-entry time bars or between 3 and 10 years. Undocumented immigrants going through the process often experience being stranded abroad without their antiretroviral medication for weeks, months, or even years. The next topic is a risk of persecution. Some immigrants migrate to the United States to escape persecution based on their sexuality or their HIV status, and fear what may happen if they become deported while applying for permanent residency. Some suggestions for support of HIV-positive undocumented immigrants are: programs should address the challenges of being an immigrant living in the U.S., experiences of racism, homophobia, and barriers that may be improved by poverty and social marginality. Access to basic needs such as healthcare, housing, transportation, and jobs may help reduce HIV risk in Mexican immigrant populations. Culturally relevant educational and training materials in Spanish, as well as education program tailored for the needs of specific subgroups of immigrants, also needed. There are increased needs for funding for support of the expansion of prevention and educational program for this population. Thank you for your attention.
Thank you. I have one question for you. What do you think the state can do with some of the, with respect to the federal challenges that we have? What do you think we can do as a state, even though we are challenged by the federal government?
I'm sorry, would you be kind to repeat the question again, please?
Sure. As a state, what do you think we can do to do things better? How do you think we can help? We're still challenged by the federal government as it relates to individuals who are undocumented being threatened of being deported. Mm-hmm. But what do you think that we can do better to help in this area?
I would believe that numbers are always going to be a challenge, as far as the estimated being 3 to 6 million, but at the same time, as far as being in a state, I do believe it's going to be challenging, of course, but at the same time, I think having a meeting in a different, starting from a county level and then to state, it's going to only going to help to spread the word around as far as the need is there, and then getting the educational people involved, what the needs are, and then addressing the issue one at a time.
You also made mention in your presentation when an individual is going through transition of being deported, there's a period that they're separated from their medication, mm-hmm. or they're not receiving medication.
Yes,
Is there's nothing can be put in place to address that, to make that better, in your opinion?
In my opinion, yes, I think we can do, but I think the patient or client, part of the clients, they are probably not educated enough as far as the great need that they need to be continuing taking it. And so they're not as willing to come up and let authority know that they're of their needs. So that's what I think.
I have something to add if you don't mind.
No, I don't.
On your first question, the federal funds that we have to support the healthcare needs of undocumented persons is very limited through the Ron White program. State funds can also be used to support this population. And also, a part of the reason why they go so long without their medication once they're stranded abroad is because the mail won't get to them. Family members try to send them the mail with their medication in it, and it's rejected. So if there's anything that can be done to ameliorate that barrier, that would be awesome.
Great. Thank you very much.
Thank you. Thank you.
Next, youth sexual health, true evolution.
Before I begin, does everyone have this sheet? It has a circle with that's most of the information I'm going to be using.
Thank you very much.
Hello, everyone. Good afternoon. Buenas tardes. My name is Jorge de los Santos, and I'm the program manager for True Evolution. So True Evolution is an organization dedicated to fighting for LGBT justice and the elimination and prevention of HIV. So before I begin, I want to talk about some of the services we offer. So we offer linkage to care. We offer housing assistance, which includes HOPWA now. We do community support groups. We do case management, insurance enrollment, and we do confidential HIV and hepatitis C testing. So this section, I'm going to talk about youth. So how do we actually approach youth, talk to youth, get a hold of youth? That's a big question that I asked myself when I first started. So I came up with the circle you see in front of you. So these are the tools for effective youth outreach. So the first point is always have a focused program. In our case, we have Youth United, which is our annual LGBT youth conference in the Inland Empire. We bring different regions or different school districts, and we house them at UCR. We also get sponsored through the UCR School of Medicine Center for Healthy Communities, which supports us not only by providing us a space, but also supports us in our health surveys that we do with the youth. So something we use at True Evolution is social media. Youth use social media all the time. I use social media all the time. So getting a contact or getting a hold of youth is actually easier in that sense. Youth rarely email, they rarely call the office, but what they do is contact us directly through our Facebook. So something that's important that we do list on our website is like our social media information, because youth use that more often. So if we can't get them through social media, we have a unique opportunity, specifically with Riverside Unified School District, to access youth directly. So we go around and we present at the high school's Gay Straight Alliances, or GSAs, which we have direct contact with youth. We tell them about our services, but we also listen to what programming they need. So something we found that was needed is kind of like an empowerment thing, and that's where Youth United kind of originated from. In our first tour, like our first high school we went to, a group of students came up to us, and they were concerned because a student, part of the GSA, was being bullied. They voiced their concerns with the adults from the school, but nothing was being done. So we were teaching them how to like advocate not only for themselves, but for each other, because it was a group of students that came up to us and told us about the problems they were having. When we do programming, we also try to focus on at least these 3 key points, which are addressing mental, sexual, and physical health. The way we address these is by, again, focused programming. So we have certain workshops that we do, certain presentations we go out and do in the community. but we also give them direct access to HIV testing. That's important because when we do on-site testing, we're able to do risk assessments. We're able to talk to youth about how does sex look to them. And a lot of the youth don't like using condoms, dental dams, finger cots, all the contraceptions. And it's up to us as testers to tell them, okay, if you're not gonna use a condom, here's a safer way to engage in unprotected sex. Here we have access to lube, use lube to prevent micro tears, and we kind of go through the steps of how someone could actually catch HIV, because there's still a lot of miscommunication. We have a lot of adults and students who think that you could catch it from hugging someone, from saliva, from shaking someone's hand. So we go and break those barriers they have, and we focus on stigma reduction, just because there's a lot of work that still needs to be done on educating that. One important thing that came out of Youth United was our health survey. Our survey really opened our eyes on the needs of the community. Some of the shocking data that we found is that students are okay with their sexual health. They already know, use a condom, use lube, etc. But what they really want is their mental health addressed now. From the preliminary data that we collected, 73% of LGBT youth that attended this conference have self-harmed, in comparison to only 6% of the non-LGBT students. So we asked another question: have you recently thought about suicide or attempted suicide? 66% said yes, while only 13% of non-LGBT people said yes. So in total, we have a group of 79% of students that attended this conference that have self-harmed or thought about and recently attempted suicide. So for next year's conference that's happening in April 14th at UCR, we are gonna be focusing a lot on not only spirituality, but mental health. Because without those two working together, we can't really address the issues that are going on. So we are still gonna focus on sexual health, but in a different approach. The way we approach stigma reduction and education on PrEP and PEP is that we host different events in Riverside and San Bernardino County. So we host these brunches that are called King's Brunch that focus primarily on Black and Latino MSMs. But recently, we've encountered a lot of our clients actually are from Los Angeles. So we do case management for Los Angeles residents. Even though we are in Riverside, we still do that case management. So the last brunch we actually had, we hosted it in LA County. Because again, we're here to service our clients, and if our clients are from there, that's where we're gonna provide the resources. We do find that LA has a lot of youth resources that Riverside and San Bernardino County do not have. So for example, recently, one of our clients needed PEP. They messaged me at 3 in the morning through Facebook. Again, our clients are using Facebook. They're not using email, they're not emailing me. They're messaging me through Facebook, hey, I got exposed to HIV, what do I do? And they were at that close to the 72-hour mark. So when I contacted agencies around here, there wasn't much they could do because the client was undocumented and uninsured. So a lot of the programs needed a Social Security. A lot of them were they would bill back to insurance companies, but they didn't have any of that. Luckily, we were able to find someone, an agency in LA that was able to cover the costs, but we had to, again, get them transportation because transportation was an issue. But we were able to solve that issue, but that's something that we just come across on a regular. How are we gonna offer better resources for youth in Riverside and San Bernardino County? But to conclude, the last point on that circle is evaluating our programs. So we get feedback from our clients and our stakeholders and everyone about are our programs efficient? At the end of the day, we want to have programs that not only reduce stigma, but address issues that HIV clients face. And at the end of the day, I want to create evidence-based programming because that's where the funding is, and people like data. So thank you very much. Do you have any questions?
Thank you. I was trying to keep up with you and taking some notes because I want to capture all the nuggets that you dropped in your presentation for us. 73% of the students you referenced 73% of the students are attempted suicide or tried to hurt themselves.
Well, 73 self-harmed.
Self-harm.
And then 6%, then that's LGBT students, and only 6% were non-LGBT students.
Do you have any resources that deals or link them to some now crisis hotline or some mental services that would try to address some of their?
Yes, we provide like all the resources. We have a resource fair at the actual conference, so students are able to directly speak with like healthcare providers. And a lot of the healthcare providers that were there were telling us how this was the first time they actually had like a one-on-one conversation with their clients without their parents being there, because a lot of times we find that students don't want to talk about these issues because their parents are right next to them. How are you going to have a conversation about self-harm if your mom is next to you, you know? So, yeah.
That's real. And then also you made us aware with undocumented who may not be insured, and therefore they have no access to PrEP or PEP. What's your thoughts in terms of us trying to address that as a state?
As a state, I'm like, hey, do you want to answer that?
We can wait if someone else will want to try to address that.
No, but
Mr. Maldonado said he'll chime in.
Good job, Jorge.
No, thank you.
So I do think that PrEP access is a major issue across the state of California, not only in terms of, there are three basic components that go into paying for pre-exposure prophylaxis. So it's the cost of the actual medication, which a lot of people subsidize through the Gilead, the makers of the drug, the Gilead Copay Assistance Program. But then there's also the laboratories and the doctor's visits. So a lot of times when we try to link people into PrEP services, they're able to get the medication, the pharmaceuticals are paid for through the Gilead Copay Assistance Program. But we don't always have the mechanisms to be able to pay for both the laboratories as well as the doctor's visits, and maintaining them in that ongoing care is a challenge because, as Jorge said, a lot of our youth are transient between the two county jurisdictions. So if there's a primary care provider that has to maintain ongoing care for PrEP, which is one of the requirements by the CDC, the challenge becomes how do we keep that client into care when they're moving between 3 different counties simultaneously throughout a given year. And so I would say that that's one of our biggest challenges, where I would say the state could do is if we are able to, one, increase the number of PrEP access clinics. So for the providers in the area that do provide PrEP, if there can be some kind of resources where they can create access points, maybe not necessarily an entire brick and mortar, but if there was like a nurse practitioner that was in select areas that they could do rapid PrEP linkage or PrEP intake, I think that would be one thing that we can do. And then I think the other thing that a lot of the providers here would agree with me is that we also have a shortage of providers, period. And so let's say the resources were there and the brick and mortar facilities were built, we are very limited in the number of actual providers who are in our region. And so I think that's a bigger question that I can't answer in this moment now.
Thank you very much. Appreciate it. Jorge, thank you very much.
That's it.
Appreciate it. Let's give Jorge one more round of applause. Thank you very much. Next, we would like to invite up the LGB transgender care.
Before I start the presentation, Mr. Maldonado, we'll go ahead and talk after the session today. We can probably create a coalition on how to address the issue on accessing PrEP and PEP for individuals in your community. Okay. Good afternoon. Hi, I'm Anthony Velasco. I'm a nurse practitioner and HIV specialist from Desert AIDS Project. And I'm with Carl Baker. Immediately after the presentation, I'll go ahead and hand the microphone to him to talk about some innovative programs that we have at Desert AIDS Project.
Thank you.
Okay? One of the key populations that we have is the LGBT community. The intersections of gender identity, sexual orientation, access to care, and HIV are too complicated to be discussed in under 10 minutes. However, I will try my best to give a general overview of the disparities LGBT individuals face in the U.S., particularly in the Inland Empire. And when I talk about the Inland Empire, this is San Bernardino County and Riverside counties. So, according to the Gallup survey published in 2017, individuals identifying as LGBT is increasing. In 2016, there's about 10 million individuals identified as LGBT in the U.S. This translates to about 3 to 10% of the U.S. population. There is such a huge estimate in this due to the differences in how data is collected, reluctance of some individuals to identify as LGBT, and exclusion of transgender individuals in some surveys. Most recent estimates near 3.5% in U.S. and about 4% in California in regards to being LGBT. Most belong to the millennials, which is people who were born between 1980 to 1998 group, and this is about 58% of all LGBT in the U.S. LGBT identity is also higher among minorities and are more racially, ethnically diverse proportionally compared to non-LGBT individuals. And most of them live in the West Coast and New England areas. How about in the Riverside County? Using the 3 to 10% estimate, LGBT individuals in Riverside County could be between 70,000 to 230,000 individuals. There are 10.55 same-sex couples per 1,000 households, making Riverside County the 5th highest ranked county in California and 33rd in the U.S. counties. Among cities, Palm Springs is ranked 1st in the state and 3rd in the nation. This translates to about 107.28 per 1,000 households. According to the California Health Interview Survey, 4.2% of adults in Riverside County identify as LGBT. But again, due to the reluctance of some individuals to identify as LGBT and exclusion of trans individuals in the survey, this 4.2% figure is believed to be an underestimate of LGBT's true population site, not only in Riverside County, but also in San Bernardino County. But what about the transgender individuals? National or local data are unavailable on the total number of trans people. However, according to a 2016 study published by the Williams Institute, there is an approximate 0.6% of the U.S. population who identify as trans. Using this estimate, the 2015 transgender population of Riverside County and San Bernardino counties is approximately 27,000 individuals. So for about 14,000 in Riverside and 12,000 in San Bernardino County. So how about health disparities among LGBT individuals? There's higher reports of fair or poor health among LGBT individuals. There's higher rates of tobacco, alcohol, and drug use. Elderly LGBT individuals also face additional barriers, more health problems that reflect many years of inadequate care, preventative screenings, and other needed services. LGBT people have 2 times higher rates of depression and anxiety. In fact, LGBT individuals and veterans are both at higher risk for suicide than the general population, which puts LGBT veterans at an even greater risk. Among transgender individuals, there's high prevalence of victimization and suicide. According to the Veterans Health Affairs, they report that transgender patients have a high risk of suicide 20 times the general VA veteran population. And of course, there's HIV. So even though overall the estimated annual HIV infections in the US have declined by 18%, LGBT, particularly bisexual and gay men, continues to be disproportionately affected by HIV. bisexual and gay men are estimated to be 2% of the population, but are accounted for 70% of new HIV infections in 2014. At the end of 2014, an estimated 615,400 gay and bisexual men were living with HIV. Of those, 17.3% were unaware of their infection. Among bisexual and gay men living with HIV in 2014, it is estimated that only 83% received a diagnosis, 61% received HIV medical care, 48% were receiving continuous HIV care, but only 51% had suppressed viral load. In 2013, it was estimated that 22% of transgender women in the US are living with HIV. These numbers are appalling. In Riverside County, 85% of all people who are currently living with HIV or AIDS are gay, bisexual, or other men who have sex with men. Since 2002, 75.5% of all new HIV infections in Riverside County have been through unsafe sex among gay and bisexual men. Since 2002, 71.4% of all syphilis cases have been among gay and bisexual men. So how do we improve HIV prevention? One of the big ways that we can do this is through universal HIV screening and linkage to care. The way that we approach this in Desert AIDS Project, not only do we focus on HIV positive individuals, but also those who could potentially be infected with HIV. So for those who are HIV positive, we make sure that they are receiving HIV care, that they are on antiretroviral therapy that's effective, that they continue to receive counseling and adherence under HIV medications. For HIV-negative individuals, we endorse safe sex practices in addition to PEP and PrEP, and also addressing STIs. Using this two-pronged approach, we're able to reduce HIV incidence. At least that's our hope. Desert AIDS Project's mission is to enhance and promote the well-being of our community. One of the great ways we do this are the multiple services we provide. We provide primary care, specialized HIV and hepatitis C care, TGNC or transgender and gender non-conforming health care, endoscopy specialty clinic, dental care, behavioral health, housing services, social services, and our sexual health clinic. We hope that by advocating and providing universal screening programs, one of them being Get Tested Coachella Valley, through our community health division and through our sexual health clinic called the DOC, we will be able to reduce the incidence of HIV. We also aim to create a welcoming and inclusive environment for caring, working, and learning. We also make sure that images on education and marketing materials should reflect the population we care for. And also, in addition to cultural sensitivity, we also approach interactions with our patients through cultural humility. In summary, it is very important to understand the demography of LGBT. This leads to a better understanding of the challenges that LGBT people face in accessing care. Improved understanding of the demographic features of the LGBT population, specifically here in the Inland Empire, we will be able to enable governments and other administrative bodies, as well as healthcare providers, to develop programs that address LGBT healthcare needs. This is my information, if you have any questions for me. And now I'll go ahead and turn the mic to Carl Baker.
Good afternoon. Thank you for your time and thank you for inviting us. I'm the Director of Legal Affairs and Legislative Affairs for Desert AIDS Project. I'm going to turn towards the future and see and sort of point out some things that DAP is looking forward to. We have this program called Prep and Play. There are handouts that are out in the front, but it's a multimedia, social media designed specifically for Black and Latino young men, specifically men, in the Inland Empire. We've sort of torn down the barriers of condom use versus non-condom use. We're trying to reach these kids, these young adults, where they live. We're trying to be real with them. So the whole Prep and Play campaign, as you can see, we use these kind of funky little doll characters, not to offend anyone, but they're all Black and Latino representation. There's a website that has actual videos and little really funny scenarios. It's a little graphic. It's not for your grandmother. We also go as far as, oh no, they didn't put that on there. We also go as far as addressing how behavior changes, how you can influence behavior. We use actual local people. We took stories from people that live in San Bernardino, in Riverside, in the Coachella Valley, Latinos and Blacks, and their stories about, oh, I met this guy and I hooked up and we went home and I didn't know what happened. I woke up the next morning. What do I do? So we just address it at a very bare bones level. Lastly, a couple other things we mentioned that DAP is looking toward. We have Section 8 housing. We're at capacity. We have over a 2-year waiting list to take more individuals. Obviously, we want to increase the availability of housing for those types of people. We also have a Hep C clinic, which we mentioned earlier, and we're opening a new transgender care facility within DAP to address the needs of our transgender population. And also, we're partnering with Equality California in a tobacco cessation project for the entire state. And I thank you for your time.
Thank you very much for your presentation. Appreciate it. With that, I want to transition and bring up Mr. Maldonado, who will lead us in a discussion. And also, I want to thank the panels who's already spoken and presented. Let's give them one more round of applause. Thank you very much for sharing with us.
Does this work? Oh, yeah, it does. Hi, everyone. How's that? Okay, good. Family in the room. So I'm like a fun facilitator, so I'm a little fun engaging. So one, I just wanted to say thank you to Assemblymember Mike Gibson for hosting this here. I know a lot of us here from the Inland Empire, we often kind of feel overshadowed by the big kind of counties that get a lot of the attention, particularly from our state legislators. And so let's just give a round of applause for the member hosting this for us. Appreciate that. So in addition to my work with True Evolution, I also serve on the President's Advisory Council for HIV and AIDS at the White House and am an advisor at the Centers for Disease Control. And so one of the things that I do is I help be a translator for community. And we take some of the public health stories that we have, the work that we're doing, our individual stories that we have when working with community from our case managers and from folks that are nurse practitioners or RNs or in the medical or clinical staff, and translating that for legislators. I would be honest with you, that translation is very difficult. Taking those kinds of nuances and taking these very large, like social systemic issues that are taking place and then being able to capture it into something that's actually achievable by a legislative office. It can be a challenge. So I designed this. It's kind of very basic and simple. It's just for a way to kind of frame the conversation around some of the key issues that we've discussed in this area and to kind of consolidate it into a way that can be used as a tool or a rubric for the state legislators to kind of pinpoint very specific things that we can be doing in the state of California to address access to HIV and AIDS. Does that make sense? Any clarity? Anything? Okay, great. So what I would just ask is, the first few discussions that we had focused a lot on geography. We also covered recidivism, women, undocumented communities, youth, LGBT, and transgender care. So that was really a focus on looking at key populations. We looked at geographic disparities. We touched a little bit on comorbidities and barriers to care, and I know some of the presentations that are going to follow will get into that a little bit more substantively. So I just wanted to open it up for the floor for anyone that kind of had comments, feedback. I just kind of want us to throw it into the space, and then we'll shape the conversation over the next 15 to 20 minutes to kind of fill this in. And I gave this each to you because we would like to collect this at the end of the discussion. So get out your pens, write, take notes, even on the back. If you guys have any suggestions on the backs, just put your ideas into the space. Don't feel limited or restricted, particularly by the 1 through 5, but obviously we could go on for days with some of these, but if we could just limit it to our 5 top most important, crucial areas that if they needed to be triaged immediately in the state of California, what would be those areas? So just open it up, popcorning. Anyone have initial thoughts? Let's start with key populations then. If we could just shout out or raise your hands, what are some key populations in our region, the Inland Empire, that are the most underserved, that we would say? Trans women, okay. Why trans women specifically? I know why, just for record.
Many different factors why that would be. Higher rates of poverty among trans women, lack of insurance, experiences with medical staff, with providers, institutional barriers, especially for individuals who are Black or Hispanic. Many different factors for sure.
And if you guys don't mind, if anyone feels uncomfortable with me calling on them, there's experts in the room that I know I really would like to hear from, so I might just call on you. So as it relates to transgender women, specifically women of color, I would really, really like to call on Reverend Bonita Ramsay. If, Bonita, do you mind just giving us a few words on transgender healthcare?
Well, what I was specifically going to address is that we have to deal with stigma within the communities, and I think that one area where we maybe didn't discuss a lot about is the role of faith communities as gatekeepers. And so I think in terms of attitude, how attitudes get shaped around sexual health, attitudes get shaped around the transgender community, we really have to work on reducing stigma and finding a way to build partnerships with faith communities that are open to healthcare in other areas, and use that as maybe leverage to build some understanding and some cooperation. But it really comes down to reducing stigma around communities and community health, especially as it relates to the transgender community and the attitudes around the very barrier in terms of how the faith community has been the purveyor of maybe harm, as well as a gatekeeper that has kept folks away from out of fear of acknowledging their gender identity publicly, because they fear for their life, they fear for their safety, and that prevents them from accessing care and coming out as being trans and seeking care until perhaps it's too late, until their condition is in a serious place and they are the victims of violence or intimidation. So I think definitely building relationships within the faith community is an important step.
So I'm going to piggyback off that because I know that Foothill AIDS Project is here in the room. They're the largest leading housing provider for housing services in both counties. And I just wanted to know from either of the contingent, and we have the executive director here, Maritza, but we can go to Anthony, okay? She's deferring to Anthony. I want to hear a little bit about the relationship with the faith communities, especially like a lot of the faith communities are some of the leading housing providers. So like CCLM. Right? Or what is the relationship with some of the faith-oriented housing services as it relates to dealing with the LGBT community, like the trans community? Are there challenges in that? No? Yes?
Well, no, it's a huge challenge. And you actually identified the only, religious organization that is actually willing to deal with our trans population. So when it comes to the culturally sensitive programming out there outside of our organizations, there's not much available. And I think, you know, with Maritza and Marie, they have all, who are our program director and executive director, they've always discussed how we're going to engage those more least represented communities within the modality of our funding sources and what our capacity is. So I think, again, I know that, DAP is doing a lot of work around that community, but I think as a larger group, a larger spread among the counties, we have a lot of work to do. And I mean, as far as solutions are concerned, it's like you're saying, Gabriel, we have to have more resources engaged into that community. And what does that look like? Who do we find? You know, I've heard many folks, even our agency, when we put out an RFP for funding, we don't have much bite from the outside community. So it's an interesting situation.
Outside faith-based community?
Well, within the faith-based community, outside the faith-based community, there just seems to be, I don't want to call it fear, but maybe, well, but that's probably part of it. The lack of knowledge in the community itself, and there's a sense of, well, we have too much to handle over here. So why do I need to add that to my bucket that's already overwhelmed?
Chuck Marbley from Borrego Community Health Foundation.
So unfortunately, we found that a good number of our transgender patients will have to drive to LA to get the extra support services that we don't have here because the programs just don't exist. There is no funding here. So therefore, they have to go to LA to get that. On top of that, we don't even have programs to train the transgender so they can get the jobs. So how am I supposed to, as an organization, hire someone when they don't have the basic skills because there's no one to teach them the basic skills? So now I have to look to LA to try to find someone to come in to work because I want them to see the faces of someone that looks like them so that I can build that trust. So to me, it's just a lack of funding in our area so our patients don't have to go to LA to get what they need.
So I'm going to take a pivot real quick and because, oh, no, yes, Marie-Francois, go ahead, from Foothill AIDS Project.
And to add what Chuck mentioned, imagine that somebody's coming from Hemet or Hesperia or Boston going to LA to get services. Transportation is going to be a barrier. And sometimes they get to LA and they have to be on a waiting list and going back. And sometimes these services have merged to other providers now who are very restrictive in terms of residency. Do you reside in LA? Well, no, maybe I can help you after we have helped the others, private funding, and so on. So it is an issue, and we have a policy of services for transgender people in the Inland Empire.
So I'm just going to take a pivot because we keep talking about funding, right? And the question that I received recently from actually Denise Lopez is here from Senator Richard Roth's office. And the question that Denise sent me was how did we get here? That's essentially what you wanted to know. How did we arrive at the place where there is a deficit of funding in the Inland Empire? How did we get there? So if I don't mind, if I can call in maybe Bonnie Flippen and Danielle Huntsman just to kind of talk about what funding sources are there in existence. Bonnie shared just a tad bit on what funding we do get from Ryan White, how that works, how that's dispensed, and why is Ryan White, the funding that we do get, why is that not enough? And then Danielle, I know we've talked about like CDC direct funding, and so just, this is nothing y'all haven't talked about before, so just talk about what we discuss on a regular basis about the lack of CDC direct funding in our region, why is Ryan White, HRSA, not enough funding for this area, and then maybe that can give a context to where the gaps are that the state could do.
And it's actually what I'm going to be covering next in the presentation that's coming up next that I have. So I won't get too much into the weeds, but yeah, our office, I can speak at least to Ryan White. We get in Part A funding for Riverside and San Bernardino County, and then also Part B for our county, and Danielle's group gets in B for Riverside County. And yeah, I mean, it's a limited amount of funding across the nation, you know, so we do our best to get in our piece of that for our two-county area. It's based a large part on formula, so this topic we talked about before, how the dollars are tied to where the diagnosis happened, is a big issue for our area because we do have a lot of people that are either moving into the area or, like was mentioned before, getting tested in other areas, and so those cases are not tagged to our area, and so we don't see those dollars come in with the formula-based funding that comes, that's how Ryan White funding works. So yeah, we're at a deficit when it comes to Ryan White. I don't know if, Danielle, you want to talk about CDC and prevention? I know that's an area too that's lacking.
So Bonnie covered it very well when it comes to Part A and Part B. So for Riverside County, we are a recipient for Part A as well as Part B, and also prevention, which comes through the State Office of AIDS. So the State Office of AIDS is typically the recipient of direct CDC funds, and then they put out an RFA, which often the counties will apply for. What we've seen is that it's typically the larger counties such as LA, San Francisco, that gets that funding. And recently, I would say probably back in April, in collaboration, Riverside and San Bernardino County, along with all of you partners in the room, we applied for a grant through the state that was, again, CDC funding coming through the state. And the purpose of that was to expand HIV testing as well as PrEP navigation. Unfortunately, we did not receive that, but it created a great platform that I think we can talk about in the upcoming presentations in terms of what does that PrEP navigation look like for not just Riverside County, but for San Bernardino County, and how we can work together, not just from a public health perspective, but also with all the partners in the room, because again, our main goal is to make sure that patients, especially if HIV or non-HIV, that they have access to care, but also those that are non-HIV have access to PrEP as well as STD and HIV funding. So there's much work to be done, and again, we can't do it without you. We can't do it without all the partners in the room. So I'm sure Bonnie and I can talk a little bit more in detail as we go on.
So I would like to go ahead and maybe turn it back to the presentations, because this is an intersectional conversation. So I don't think we can get through the conversation without touching on presentations that haven't happened. It's going to be impossible to not have it at once. So if we can just go back to the presentations, and then maybe we can end with kind of a full circle round out of the discussion.
Well, let me say, Mr. Maldonado, thank you very much for your facilitation of this. This is something we've never done before. Certainly, I enjoy this format because I think bringing and having the audience interact with the facilitator was very, very important. So, and also this is, also this is being live streamed, and so it's seen all across the state of California, so other people will also see what's going on here as well, and I'm sure they'll be chiming in at a later date. I also want to take an opportunity to recognize Senator Roth's office. Ms. Lopez is here. Would you please stand so we can recognize you, and thank you very much for coming. Let's give her a round of applause. Again, thank the Senator for at least allowing you to come. We really appreciate you being part of this very, very important discussion. So with that, we want to bring up our next panel, Gaps in Services Delivery, Coverage, and Challenges.
Power numbers. And hopefully everybody got these documents. One of them is called the HIV Continuum of Care Resources in the IE. Looks like this. This is really the basis of the presentation that I'll be going over right now.
I need one.
Okay.
Yeah, thank you.
And also this two-page document stapled together called Riverside San Bernardino Service Sources. That'll be another one that should be helpful too as I go through.
Thank you very much. Please introduce yourself and your organization.
Sure. Well, thank you for being here in our area. I appreciate it, and thank you for the opportunity to speak today. My name is Bonnie Flippen. I am admin soup with the Ryan White Part A and B programs in San Bernardino County Department of Public Health. And we administer the contracts for Part A and Part B in this area. What I'll be covering today, like I said, that handout that I gave to you, that matrix, goes into a lot more detail than what I'll be covering in the presentation. So be sure to look at that and review that, because that'll give you a lot more information than I'll give here. To really delve into that, we'd probably need a good couple hours to go through all the great resources that we do have in this area, and then also the gaps that we've already been talking about quite a bit already. So I'll be covering the way this matrix has been laid out, and it is a draft because it's a fairly new document, and so it's a living document that has a lot more that could be added to it and a lot of tweaking that could be done to it, so it is a draft. But it's laid out using these stages of the continuum, and through that framework, then I'll walk through the various activities and services along the continuum, and then talk about the resources in this area, what I like to call who in the IE is doing these things, and then a little bit on the notable gaps then that we're experiencing in this area. So the HIV care continuum, which Kim hit on in the EPI presentation, these aren't the exact numbers for our area, but it gives you an idea of what we're looking at as we move folks through from becoming HIV positive all the way through to being virally suppressed. And at different stages along this continuum, there's different opportunities to institute activities and services to address those gaps, to move these bars up so that we have more folks diagnosed and linked and then ultimately virally suppressed so that we can get to that zero goal. So there's 4 basic sections in the matrix in front of you that we've framed this around. First, prevention, to keep people from becoming positive in the first place. Then testing, diagnosis, to make sure individuals that are positive know about it so that they can take care of their health, become healthier, and also protect their partners around them and the community. And then linkage or retention, to then ultimately get to the ultimate goal of viral suppression. So again, I'm not going to go over every single detail of this, but these particular 4 categories and the activities that are listed are generally the agreed upon necessary activities to support individuals as they move along this continuum of care. For the HIV prevention category, this includes things, and if, again, we've already discussed these at length, so I'm glad we've already had a good discussion about these. But PrEP uptake, getting folks that are not positive on PrEP to reduce transmission. The integrating of STD and HIV approaches and activities and interventions, because those really do need to work together better and more efficiently and effectively. Also and services, making sure that those that are positive have resources to notify their both sexual partners or injection drug use partners about their status, so that they can then take the steps to get tested and be aware of their status and either get into care if they're positive or know how to keep themselves negative. And then syringe exchange programs designed to provide access to clean syringes to reduce transmission among injection drug users. Then moving to and that of course for all of these, a big component, not only just the provision of the activity itself, but making sure that there's the knowledge out there about all these different options, both to the individuals so that they know the services that are available, but also making sure that providers are educated about what's available so they know what to offer their clients, and then also to educate their clients about the options that are available to them. So that kind of plays through all of these 4 categories of continuum. The second being testing and diagnosis. There's 2 major areas around this as far as generally accepted activities. One being the targeted HIV testing, and that's various types of rapid testing. That also includes education and counseling. But also more and more the routine opt-out HIV testing that we've talked about, incorporating that in regular lab tests. The general guidance around that is that anybody between the ages of 15 and 65 really should be getting tested at least once in their lifetime for HIV. And then those that are at risk should be tested annually. Those at high risk, every 3 to 6 months is kind of the general idea around that. Then the third category, keeping folks linked or getting folks linked to care and then retaining them in care. The two different ones we discuss on the matrix are that the data-driven identification, so using surveillance, both diagnosis data that the state has, but also now the state is collecting lab tests. So that we can see who's actually in regular care, and if they're not getting those lab tests and that's not in the data, then we have an idea of who we need to go out there and grab up and say, hey, what's going on? What do we need to do to get you back into care? And then that plays into the barrier assistance then activities, both with the cost assistance programs to reduce financial matters, and then also all the different support services that go into it, the housing that we've talked about, transportation, food, benefits counseling to make sure folks get connected to the benefits that they're eligible for. And then finally, treatment and the ultimate viral suppression. And that includes things like antiretroviral therapy, making sure they're connected to those medications that they need. And more the guidelines are looking at doing that immediately once folks are getting diagnosed, to immediately get them onto treatment. And then finally, the comprehensive care and support, having a full team, a dedicated team that addresses all the issues, both mental health and physical health issues of an individual, to make sure they're healthy, making sure that those services are accessible, whether it be using telehealth or some other methods to reach out to those, especially in the rural areas, to make sure they have comprehensive care. And then other medical type services like oral health, nutrition, home health for those that need those particular services. So who in the IE are supporting these activities, and both providing and supporting these activities? The number one is insurance in this area, for these services, of course. Since the Affordable Care Act came around several years back, we've had a great increase in enrollment in Medi-Cal, thanks to expansion, and also some folks in Cover California. So you can see by this graph, and this is just our Ryan White folks that you're looking at here, but it reflects across the population. From 2011 to 2016, you see the great increase in enrollment in Medi-Cal, and then also then, of course, Medi-Medi. We went from under 50% of our folks being enrolled in those insurances to now over 80% being enrolled. So that's a huge resource for our individuals in this area, and a huge support in at least medical care, dental care in some ways, and some mental health services as well. Our two major plans really for Medi-Cal in this area are Inland Empire Health Plan, the IHP, and Molina. And then the flip side, then, of course, you see the great decrease in those that don't have any insurance. So that's been a great benefit all across the board, really. So in the provision of PrEP for those physicians that are prescribing that in our area now, the clinics that provide STD treatment, the hospitals, the ones that are doing routine opt-out testing supported by insurance plans, payment for medications, and then, like I said, the comprehensive care like dental, some mental health services, and home health. Then we have the cost assistance programs that really benefit the folks in this area, and the two major ones are PrEP, for supporting PrEP, and we've talked about this already. Gabe brought up Gilead's Advancing Access program, and then the state's also going to be implementing the California PrEP assistance program the beginning of 2018 into the spring of 2018, so that'll also be beneficial to our folks here in our area as well. And then the premiums copay cost assistance program, Office of AIDS has their health insurance premium payment program that will assist those that are in Cover California plans to pay for their premiums and also their copays. So really anybody in this area that is either able to get Medi-Cal or able to get Cover California should be covered when it comes to medical care, as far as having some sort of insurance plan in those cost assistance programs. So then, in a similar kind of vein, then our federal and state programs that support all along the continuum. We have the Centers for Disease Control that supports a lot of prevention programs in this area, PrEP, the HIV, STD, and tuberculosis type interventions, partner services, testing, surveillance, and health education. Then we have HRSA that provides a lot of resources for HIV care, and that's especially for our office, is near and dear to our heart, the Ryan White Parts A and B, that provide not so much the medical and medication type assistance as much anymore because of Affordable Care Act and those things being supported by Medi-Cal more so, but those support services and those wraparound services that are really needed to address the barriers to care that our folks are facing. And then ADAP, which is really a part of HRSA and the Part B under HRSA, but it's such a major support in the state that I felt it necessary to give it its own bullet, because that's really important and used by many folks in our area. And then HUD, HOPWA, is an example of the housing assistance, and I think Anthony can speak a little bit more to that, both the benefits of that in our area, but also the challenges that we face and the gaps there. And then finally, the state, California Department of Public Health, provides their own, assistance through general funds, especially in this area around testing and PrEP navigation. And then we have our county governments, my San Bernardino County and Riverside University Health System, their public health department. They've put in a lot of resources around these areas: surveillance, disease investigation, testing and outreach, our county clinics and our 2 major county hospitals, and then, as we talked about before, the collaborations with the correctional system, like our reentry collaborative in San Bernardino County, are big resources. And really, most of all, and finally, our backbone really of the services that are provided are our organizations, our community-based organizations in this area, and we've heard a lot from a lot of them already today. They're the ones that are really the experts and have their finger on the pulse of the needs of the community and how best to approach their needs. So we really owe a lot to the great work that they've been doing over the years, really since the beginning of the epidemic. And I do have out on the front table a brochure that lists the Ryan White, at least, Part A and B contracted agencies that we work with, lists their locations, their hours, and also the services they provide. So I encourage you to pick that up if you have not already. So then, notable gaps. Again, I'm just going to touch on the surface of this, and then I'll let Erica and Anthony hit on some of the things that they have more expertise in at the provider level. And we've also discussed some of this already in our conversation, but with PrEP, it's getting more physicians out there prescribing PrEP, and a lot of that stems from physicians not having the knowledge and understanding really the guidelines and the benefits of PrEP to really stand behind and support prescribing PrEP. So more of that is needed. When it comes to partner services, we have great individuals in both counties that are doing great work around partner services, but there's not a whole lot of funding there, and therefore not a whole lot of staffing to do all that work for the 2 counties. So that's needed, as well as, again, knowledge, spreading the knowledge about the availability of partner services both to individuals, so they know that service is available, as well as providers, healthcare providers around the area, so that they know to send their patients to that service for assistance. Syringe exchange, knowledge and support, that's an area in our 2-county area. We have not implemented that yet in our jurisdictions, so that's definitely a place that we need to look to and get more information to be able to spread the knowledge about that and garner support. It's a touchy subject in a 2-county area that's very conservative, and real concerns for law enforcement and the community as well. So finding ways to address those concerns and bring that knowledge to the area is something we need to work on. Again, as we discussed before, breaking down those stigmas and increasing the communication around these newer tools. Then when it comes to testing, again, funding and staffing for targeted testing, but also getting the word out about routine opt-out testing to healthcare providers in the two-county area. We have, DAP talked about Get Tested Coachella Valley. They did a great job in that initiative, getting out there and getting hospitals on board in that area to do more opt-out testing, and we've seen fantastic results there. We need to spread that across the two-county area more. Also, our hospital here in San Bernardino County, Arrowhead Regional Medical Center, they have started doing opt-out testing in their ERs, and they've seen some great stuff come from that as well, where they've had actually more positivity. So they've seen more positives than from the methods of their doctors doing their own targeting. So that's been eye-opening for those physicians to see that, oh, okay, maybe there is a reason for a push for routine opt-out testing. So just getting that information out there more and spreading that across the two-county area is needed. And then when it comes to linkage and retention activities, data-driven identification, there's still a lot of rules and restrictions, not as many as there used to be, but still some that restrict to some degree the communication that we can have between not only Riverside and San Bernardino County, but out to our neighboring LA and Orange County and such on what data we can share about cases. And then definitely barriers from what the public health department can share with our partners in the community, the community-based organizations, so that we can leverage all of these resources together to get out there and get these people back into care. So those are a gap and a barrier. And then finally, with linkage and retention, barrier assistance, there's a lot of regulation around various grant funds, especially Ryan White, those of you that provide those. And I hear your pain every day when you talk about all the different regulations you have to follow. So that really, it makes folks a little gun shy on how they can use funds, and it limits how we can use those funds. So breaking down some of those restrictions, although we understand the need for those eligibility verification rules and such, finding a happy medium in there to reduce those barriers is necessary. And then we talked about shortage in rural areas of some service providers, and then service-specific gaps, which I'll let Erica and Anthony get into more. And finally, when it comes to treatment and viral suppression, there's still some hesitation around immediately treating folks with antiretroviral therapy. So getting some more guidance from the state and getting some more guess you could say respected, guidance out to the physicians, so that they hear it and they understand and they believe the new guidance for antiretroviral therapy and other new methods, or new because they're advocating immediate treatment. And then finally, comprehensive care and support. As we've heard before, there is a shortage of HIV specialists in this area. We only have really a handful that serve this huge geographic area, so trying to get more talent, quote unquote, into this area so that we have more options for our clients to go to. Getting more service access in the rural areas, breaking down some of those barriers between insurance plans. You have to be in a certain county to get this insurance, and this insurance covers that but not that, or this doctor has this insurance but not other insurance. Those all create barriers for our folks. And then the county line barriers as well. So to just wrap up my section here, as far as what we're working on, as you know, the state put together California's Integrated HIV Surveillance, Prevention, and Care Plan, and that's really become a strong basis for jurisdictions to build off of, where we're really working to have those methods work together more to be more efficient and make a stronger base for our activities, and not work in our silos like we've been doing for years and years, right? So that's really pushed forward that step for collaboration. And from that, and Danielle mentioned the second point here, the Inland Empire HIV Prevention and Care Coalition, that group was started in that effort to get that grant money and that she talked about that we were not able to get. However, the pulling together these folks, that includes HIV positive individuals, healthcare, physicians, service providers like FAP and DAP, Also the insurance plan representatives and board members and city, council members, those type of folks, getting them in the same room to really sit down and have discussion around PrEP, around testing, and really what do we need to do as a community together to get to zero. That coalition has been very beneficial, and I encourage anybody here who wants to have a voice and give their ideas for how we can move this two-county area forward, come to these meetings because they're great. And then finally, the Inland Empire Planning Council, they every year are working on service planning, and then this next year they're going to be doing a local needs assessment to build off of the California needs assessment that was done to get more local data on what our clients here need to address the various barriers and whatever the sticky points that are preventing us from getting to that 0 point. So I do have both the IHP or Inland Empire HIV Planning Council brochure and their application for anybody who knows somebody who wants to be on the Planning Council out on the table. So I encourage you to take a look at that. And that's the end of my piece. So Erica and Anthony, I'll let you elaborate on your areas of expertise when it comes to resources and gaps.
Okay, thank you again. My name is Erica Washington, and I'm coming to you from AIDS Healthcare Foundation. I'll first touch on the available resources that we have in San Bernardino and Riverside counties. So my agency, AIDS Healthcare Foundation, offers services in both counties, including outpatient ambulatory healthcare services, medical case management, non-medical, transportation services, dietitian services, linkage to care, and in Riverside County, outreach and linkage to care in medical and non-medical case management. AHF is the largest provider of HIV and AIDS medical care. We offer cutting-edge medicine and advocacy regardless of the ability to pay to over 700,000 people in the United States, Africa, Central America, and Asia. These are some facts about the agency. Some that I wanted to highlight are that there are over 840,000 clients being served by AHF worldwide in 38 countries and out of 453 global clinics. Some of the services provided are pharmacy services, out-of-the-closet thrift store services, wellness centers, testing and mobile testing, and we give away a lot of free condoms. Foothill AIDS Project is another agency that provides services to the HIV and AIDS population in San Bernardino and Riverside County. Some of those services include medical nutrition therapy, mental health services, early intervention services, outreach and linkage, substance abuse, case management as well, transportation, housing, food, and psychosocial support services. And FAP offers a full spectrum of programs and services that empower clients in three counties to manage their own long-term health goals, integrated treatment and chronic care management paired with stable housing. Planning and outreach provide many tools for people living with HIV and AIDS to live longer, healthier, and more stable lives. At True Evolution in Riverside County, linkage and retention is offered, housing, case management, behavioral health services, HIV testing, supportive services, youth organizing, and health education, to name a few. True Evolution is a 501c3 organization dedicated to fighting for LGBT justice and prevention and elimination of HIV and AIDS in America. Riverside County Department of Public Health provides education and prevention, outpatient ambulatory health services, partner notification assistance, medical nutrition therapy, STD testing, early intervention services, and linkage and retention. The Sexually Transmitted Disease Program's mission is to promote healthy sexual behavior and reduce the impact of STDs in Riverside County. Trends in existing and emerging STDs are monitored, and new knowledge about STD risk, behaviors, treatment, and prevention is gathered on an ongoing basis. Desert AIDS Project offers outpatient ambulatory medical care, dental care, medical case management, medical nutrition, mental health services, early intervention services, linkage and retention, substance abuse services, outpatient, home and community-based health services, case management, non-medical, transportation, housing, food, and psychosocial support services also. This agency was founded in 1984 by a group of volunteers in the face of the AIDS crisis. DAP has been the Coachella Valley's primary non-for-profit resource for those living with, affected by, or at risk for HIV and AIDS. And then there's Borrego Health in San Bernardino County, who offers outreach, linkage, and retention, and specialty health care, to name a few. Under Dr. Clayton Barbour's direction, the Borrego Health Specialty Care Center was established in 2013, aiming to provide excellence in health care to hepatitis C and HIV/AIDS patients. In 2015, the clinic expanded its services to transgender health. Their providers now offer appointments at Riverside facilities and San Bernardino facilities, in addition to existing services in Desert Hot Springs and Cathedral City. SAC Dental offers HIV dental services in San Bernardino County. Their name is Social Action Community Health System, and their mission is to improve the health of San Bernardino community families. Their mission to improve the health of San Bernardino community families is central to every decision that they make. Their mission has driven them to provide affordable health care services for over 40 years now. I now take this opportunity to provide some overview of some gaps in services. In California, significant health disparities exist across the HIV continuum of care. Persons living with HIV, who are among the most vulnerable and underserved populations, face severe stigma and encounter other socio-structural barriers that poorly impact their care along the HIV treatment cascade. My personal experience with a client involved him expressing how a dental visit went. When he went for services, he was treated pretty poorly and humiliated in front of other clients when he went to receive those services. The client cried to me as he explained how the dental provider went into a state of panic as they read his chart and discovered he was HIV positive as he was lying in a chair fully prepped to receive his procedure. He was immediately removed from the clinic in a very indiscreet manner by staff dressed in protective clothing without receiving the care that he needed that day. Fortunately, the client was able to receive dental care through SAC's Dental and has praised them, along with many other clients, for providing them with quality, dignified service, as they are trained in HIV care and they understand the needs of the HIV patient in a much clearer way. What is the need? More HIV specialized service providers, especially medical providers, dental services, vision services, counseling services, and transitional HIV housing services, in addition to mobile testing. More education needed in the community on the needs of HIV persons and how to provide services in a way that promotes dignity and respect, for sure. And also mobile testing units that can also offer many advantages, such as testing and diagnosis in an earlier stage. Diagnosed clients can receive results and be linked to care right away, and it's easier to reach the hard-to-reach and high-risk populations and test them. The current situation concerning Blacks and African Americans, both nationally as well as here in California, African American people are disproportionately affected by HIV, as we learned earlier from the epidemiologist. Historically, Black people experience higher rates of infection, higher rates of HIV-related death, and low rates of viral suppression. African American men and women represent 5% of the country's population, yet make up 12.6% of individuals diagnosed with AIDS in the country. Furthermore, 75% of positive African Americans achieve viral suppression versus 90% of HIV-positive whites and Hispanics. Lower rates are even reported among African American women and African American transgender persons. African Americans in 2013 represented 47% of all estimated deaths of estimated deaths of people ever diagnosed with HIV. A recent study also showed that Blacks diagnosed with HIV are less likely than other groups to be linked to care, retained in care, and receive antiretroviral treatment and achieve adequate viral suppression. African American men accounted for 40% of HIV cases diagnosed among men in the U.S. and 6 dependent areas in 2014. mental health and substance abuse, dual diagnosis inpatient recovery centers. And another experience that I had recently, a client came into my office with all of his belongings and did not want to return back to his partner, as there was a domestic violence situation, as well as the partner was also addicted to meth. And he wanted to get into an inpatient substance abuse treatment facility immediately in that moment. He was homeless and experiencing withdrawals from his addiction. He was experiencing paranoia while in the office and visual and auditory hallucinations. Myself and medical case manager Susan Cho spent over an hour on the phone making repeated phone calls to try to find him somewhere to go at that moment. And every facility that we contacted that accepted his insurance had a long waiting list, and he would not have been able to be admitted that day into treatment. As he was waiting and listening, as we made the phone calls, the client became increasingly paranoid and began to become discouraged with the fact that we could not find a place for him to go. He gave up and he left our office without getting treatment that day. And so we missed the opportunity for him to get treatment in a moment where he was able to overcome both his substance abuse and his mental illness to focus on the fact that he needed help. Supportive interventions are needed. In my experience as a case manager, I've witnessed the extent to which many African American males are affected by several of the following variables at once: HIV, mental illness, homelessness, substance abuse, unemployment, and/or a detectable viral load. More specialized interventions are needed to specifically address the testing needs, education and prevention needs, linkage to care needs, overall health care needs, and barriers to care that affect Black and African American men, women, and youth in our community. Supportive housing, where most of all of these areas can be addressed while meeting the need for shelter, would be great if they could go to a place where they can receive mental health treatment and substance abuse treatment and possibly some job education support in the same place would be awesome. Also, dual diagnosis, detox and recovery centers for uninsured and underinsured clients will help a lot. Thank you.
Thank you. Anthony?
Okay. Again, I do apologize. I don't have a presentation, but I'll do my PowerPoint presentation, but I'll do my best to have a conversation, and I'll be to the point. And then this also gives me an opportunity to have a dialogue email-wise, because as we have all those resources, I truly believe housing is a big component to supporting the improvement of clients that we serve in this community. And these housing comes in many, many forms, through housing to help those clients who are critically ill and needing support, or at least a roof over their head with services around them, and then those who are considered chronically homeless or pass through homeless, or those who are financially, how can I put it, tied to that population due to their low income, through their income or lack of income resources. And so HOPWA is our provider, funding provider for housing for both counties, Riverside and San Bernardino. And they primarily provide permanent housing funding for those clients who do have enough income to be able to move into housing. Then we have the Rapid Rehousing Fund, or the fund that helps clients who have run into financial straits and be able to stay in their housing. And we do have emergency housing through True Evolution that's doing it through HOPWA, as well as Ron Wright that's providing a majority of the emergency housing. And it's wonderful, and it's doing a lot of wonderful work, but we have a lot of gaps in housing. And the number one gap is affordability. You have a large percentage of our clients that come through our office, and I'm sure that DAP and all the other agencies can attest to this, that all of them are around 0 to 30% poverty line. And that creates an issue when rents are increasing. So our stock is shortening. So from a state level, is helping our organizations who serve that population. How do we come up with more affordable housing? What does that look like? I think, again, the other gaps and that we are in need of is funding and support for those clients who are in crisis, like Erica eloquently expressed here, in terms of housing. A lot of times, I have to get, sometimes I have to tell my housing case managers, they spend up to 3 to 4 to 5 hours trying to find housing solutions that we are ready to able to find. Sometimes we have to put them back into homelessness and then pray that they come back the next day and let's try this again. So housing is crucial. We have a lot of those resources that are carrying our clients, but then there's a lot of clients that we're missing gaps. Transitional housing is missing here for our clients, and supported permanent housing. And it's for those clients with those multiple occurring issues that need not only the housing, but in addition to that wraparound services to hopefully maintain their housing. So that's my say.
Well, thank you very much for, again, a nugget. I know the City of Los Angeles and the County of Los Angeles have passed some measures to try to do their part in terms of addressing the housing shortage. In Los Angeles County, each night there are 47,000 people who are living on our streets in Los Angeles County, and 650,000 children go to bed each night hungry with no food. And that's alarming and disturbing to me, because we are the 6th world economy, and the riches are right here in California, but yet and still we have this vast population that is not being served. But that's the reason why this conversation is important, for us to be able to share this information and also come back with policy solutions. This legislature passed a housing piece of legislation, and it still wouldn't put a dent in the housing shortage and crisis we have in California. Certainly doing nothing was not an option, so we are, again, a legislature that are looking at trying to do everything that we can possible for people who live within California, and trying to address some of the issues such as you bring out. And I want to thank this panel. I have a couple questions for you. One question, if anyone can answer on the panel, that would be great. What are some of the streamlining measures that you would find useful in providing services to at-risk individuals?
Streamlining measures?
What do you mean by streamlining? So you mean like coordination?
Absolutely.
Okay.
Because everyone is doing their own thing.
Right, the silos.
Absolutely.
Yeah. Yeah, and that's one area that we are, at least from the county perspective, then I know Riverside has worked in integrating a lot of their, across the surveillance, prevention, and care work. And then in San Bernardino County, we're also stepping towards that. We're not quite where Riverside is yet, but we are working on linkage collaboratives that are bridging those gaps between surveillance, prevention, and care to try to make that happen. Any guidance that we get from the state, just because that is a voice of authority a lot of times, in our area, that helps our administrations and our officials understand the importance of doing more work around that. But again, we are stepping towards there, and there's some work to do, but that is being done.
And I think from a housing perspective, in terms of the state can help, is somehow getting those cities, counties, those who are engaged in homelessness, and starting to look at, how do we create friendlier housing solutions, development of housing solutions within your community. You know, looking at zoning issues, looking at those types of things that are, when there were opportunities to create more affordable housing, it seems to have gotten sidetracked with the reductions of some funds that used to come from the state, and now agencies having to try to be creative in the way that we try to look and develop those housing. So, how can I put it? I think that streamline is, from a housing perspective, is where are those coming from? Where are they coming from the state? The I guess the oh my goodness, the initiatives, the policies, to more to sort of take to the ground level community to help agencies like Foothill Age Project, True Revolution, DAP, to develop those housing targeting HIV positive people.
I'm reminded that I think it was a piece of legislation I was looking at, but I think there was a hang-up somewhere where the state couldn't fully grasp the concept. And because we abolished, long before I got to the legislature, because I was a local city councilman and was against abolishing redevelopment, but counties have a surplus of assets that they're sitting on, and I wanted to use those assets to put people in and create an opportunity for low-income people to actually own their own homes. But this may be a conversation to take those assets. I think we're looking at 10% or a percentage of those assets that all the counties have in California, and move people in those assets so they won't just sit there idly and not being utilized. So maybe there's an opportunity we can revisit that with an emphasis and a focus on the homeless population, especially possibly those who are living with HIV and AIDS. So thank you very much. I appreciate you. Let's give this panel a round of applause. Think that together. Next, I would like to invite the regional variation of from Riverside and San Bernardino County up. We're right here.
Okay, good afternoon.
Good afternoon.
I don't believe I have a PowerPoint.
Okay.
No, I don't. But first and foremost, I'd like to thank the Assemblyman for being here today and conducting this hearing. I think it's really well deserved and very timely, obviously. And I also like to thank all the panel that spoke before me. Obviously, they took the thunder out of what I had to say. A lot of those things have been presented in terms of data and some of the issues that, in terms of the gaps and the barriers, they've all been talked about. But so what I want to do now is actually rehearse some of what they've said and maybe put my own personal comments on what I think is happening or where we can go from here. So to start with, we know that the region of, we call it the Inland Empire. There's a reason why we do that. Because when we travel out of this county, or Riverside County, nobody knows us as San Bernardino or Riverside. They know us as Inland Empire. Is that how you guys know us at the state too, legislators? I'm just curious. I know it's okay. Yeah, they actually know us as the Inland Empire because there is no barrier. There is no wall that separates us. Our citizens flow back and forth. With that said, we have a lot of things more in common than what we don't have in common. So to reiterate, the Inland Empire covers a span of 27,000 square miles. We are the largest in the continental United States. with a population of over 4,400,000 residents. We're actually larger than five states in the United States, which I'm sure you all know that. We're larger than New Hampshire, New Jersey, Connecticut, Rhode Island, and Delaware, all put together. So that gives you an idea of how geographically challenged we are when it comes to any type of disease, not to talk about HIV. There are 52 incorporated cities in both counties combined. And the ethnic diversity is almost 50% Hispanic, about 35% Caucasian, and between 7 to 8% African American. There are a lot of folks that have traveled or migrated from Los Angeles County, Riverside, Orange County, and even San Diego County to move into the Inland Empire. They probably work somewhere else, but they live here because of the affordability of housing. So now, those are things that bring us together. Now, there are some of the things that I believe that maybe we're a little bit different, and most of those are usually in the incidence of HIV because we're talking about them right now. First and foremost, San Bernardino County reported 43.8% of all new cases of HIV in both counties. There are higher number and proportion of females with HIV in San Bernardino County. The higher proportion of men having sex with women, men having sex with men in Riverside County. There is a higher number and proportion of intravenous drug use and heterosexual transmission in San Bernardino County. Obviously, there are a higher number of whites in Riverside County. There's a higher proportion of African Americans, Hispanics, and other non-white groups in San Bernardino County. The higher proportion of ages 25 to 44-year-old in San Bernardino County, and vice versa, higher proportion of people over 45 years old in Riverside County. So these are the data that actually separates us with regards to the incidence of HIV. But I'd like to submit that there are more things that bring us together as a TGA. And those are things we actually should focus on. And when you look at the barriers that everybody has talked about, whether it's housing, whether it's transportation, whether it's funding, we're in the same boat in both counties. So there's not much of a disparity when you get to that. So when we talk about getting to zero, I actually like that slogan, getting to zero. What do we really mean by getting to zero? And I guess different sectors might look at it in different ways. When you talk to public health folks like us, we look at it in a comprehensive way. Now, you've heard a lot of community-based organizations and providers and experts, subject matter experts, that have testified here today on what they're doing in their each individual sectors. I like to have an approach that is all hands on deck. Now, when we look at that concept, all hands on deck, it means every one of us, irrespective of who we are, irrespective of organization, we should all come together and look at what can we do to reduce this incident of HIV, of getting to zero. Okay, let's look at it from a prevention standpoint. Obviously, that we all talk about prevention. What do we mean by prevention? We want to be able to make sure that people get tested, people are identified that have HIV, because there's a good proportion of folks walking out there that have the disease and don't even know about it. Now, you asked a question earlier, Assemblyman, about what about mandating testing in the jail or the prison? And obviously, I mean, the way to answer that is not the mandate, but one of the things you can actually do is to provide that avenue to be able to test everybody. Whether it's an opt-out method in conjunction with other testing, and we are currently doing that in all our jail system within San Bernardino County, where everybody that's booked, they go through an education, and then they're offered testing, not just for HIV, but for other sexually transmitted disease. And that's partly because of the high rate of syphilis that we had in our county. And that was a pilot project which was funded by a board of supervisors. I submit to you that that can be done everywhere across the state. That's a good way to get started. You've heard testimony today about folks talking about the incarcerated folks, how, and I was sharing with Assemblywoman Reyes about stories that I've heard of inmates that will tell you, look, when I was in there, I lived a totally different lifestyle. When I came back home, I was back to normal. Basically what they were saying was, when they were incarcerated, they participated in those type of activities, having sex with men, and then when they came back home, they're heterosexual. And they consider themselves heterosexual. And I submit again to you that when we looked at this a few years back in San Bernardino County, we realized that there are more women coming down with HIV. Why is that? If you remove the proportion of the intravenous drug users, why are they getting HIV? They got it from somebody. So I think that project we started in jail in about, we just started that about maybe 4 or 5 months ago. I think that it's a good pilot program that I think can be replicated anywhere. And I think the California State Public Health is actually very happy that we're doing that.
And that was implemented by the Board of Supervisors here?
Well, actually, we in Public Health, we presented the data to the Board of Supervisors and requested, we partnered with our Sheriff's Department, and we made the Sheriff's Department go get the funding. Why did we do that? We know that. You know, when it comes to law enforcement, I think there's a soft spot for them. So it was a partnership between us and the Sheriff's Department. So they got the funding, and they were able to hire folks that will conduct that. So we were able to do that. Now, again, so we're talking about identifying people that are infected with HIV. We also need to do a better job connecting with our faith base. Just like Ms. Ramsay said, the power of the pulpit is very, very, very strong. We know that when you look at the communities that are impacted by this, particularly the African American community, there's one thing I guarantee you that they do every Sunday. They go to church. They believe in that Almighty God. They go to church. They listen to their pastor. How do we get the faith-based folks to actually take this on and say, you know what, just like we talk about all other type of diseases, whether it's diabetes, hypertension, cancer, or anything like that, why can't we be the venue to preach to folks about safe sex, about getting tested? So that's one thing with the jail. The other thing is, how do we get our providers within both counties to test folks? Just like Bonnie said, once a year, once in a lifetime. If you're high-risk category, you test more often. If we do that, we'll be able to pick up HIV from people that don't even know they're infected. So that's another way. And thirdly, some of the barriers that we're both experiencing in both counties, Anthony talked about housing. Housing is a huge one because we don't have enough units anywhere, and I think in the state to accommodate that. Even LA County, with the new proposition they had on in terms of building more units, I don't even know if that will scratch the surface. The problem we're having, and I'm sure it's not us alone, is that even if you get the funding, most of the cities, they are autonomous in what they decide to do. There is this adage, not in my backyard. What that means is, I don't want those units in my backyard. We have to overcome that, and the state can help us do that, overcome that, so that as we have resources to build those units, they can happen at every city. The other issue that unites us, but it's a common barrier, is transportation. We talked about the vast geography that we have in both counties. I mean, San Bernardino extends all the way to Needles, which is what, 4.5 hours away from here. How do we get to those folks? How do those folks come down because there's no access to health? What do we do about transportation? We don't have a coordinated effort in terms of how the transportation works. I'm throwing some of these challenges out, not because you can solve it alone, or we all can solve it, but it's something we actually really need to consider. Because just like one of the speakers said, if people can't get to care, there's nothing you can do. The other one is workforce in both counties. We know that the ratio of providers, there's one provider to 1,800 residents in San Bernardino County. In the state, it's 1 in 1,200, and in the nation, it's 1 in 1,000. So if you look at that gap alone, that access to providers, access to health care, even if you have insurance, it doesn't matter. If you can't get to a doctor, what good is it? So that's a huge issue. Our workforce development needs to improve so that we can meet some of those challenges. And somebody mentioned that is just the data for just all the providers. Now, when you narrow it down to people, the infectious disease specialists or people caring for HIV, that number goes way down. We have a handful in San Bernardino, maybe a handful in Riverside. Not enough access to these folks. So we, as both counties, we need to improve on how do we attract infectious disease specialists to come to our county, both counties. So those are some of the issues I see right away, and I think they've covered a lot of the barriers, a lot of the gaps, and I will stick around a few more minutes. Maybe we can, if you have any questions, I'll be able to answer that. Again, I want to thank you for doing this. I think both counties thank you immensely, and we hope to see the white paper and some changes at the state level.
Thank you very much. Let's give them a round of applause. Thank you very much. Next we will have East Valley and Western Region. Okay. Please.
You don't have any questions, right?
No,
not right now. Okay, great.
Thank you very much.
You're welcome.
We invite you to take a seat at the table. Welcome, and please introduce yourself, and you can start right on into your presentation. Both microphones work. The green light should be on. You can, each one of you have a microphone. Great. And then we have one more panel. Then we haven't forgot the public. So please stick around, and because your input is very valuable to us.
Assemblyman, ladies and gentlemen, Thank you for giving us this opportunity to come and speak with you today. My name is Chuck Marbley. I am the Vice President of Specialty Care at Borrego Health, and I am also an RN that works in HIV and infectious diseases.
Thank you for the opportunity. My name is Eric De La Torre, and I'm a Linkage Care Coordinator with AIDS Healthcare Foundation.
Thank you. So just a quick background on who Borrego Health is. We are the largest FQHC in Southern California. We have 24 clinics throughout Riverside, San Bernardino County, and San Diego County. We service 166,000 patients with 800,000 visits. We have 2 specialty clinics. We started in 2013 with an HIV clinic in Desert Hot Springs to deal with that rural area. We then grew and expanded the clinic to Cathedral City, and we have 7 HIV specialists in that particular area. I'm going to dive right into the gaps in care because some of the folks in the room will give me a quick amen on this. One of the biggest problems we have, as the doctor shared before, is getting providers in the rural markets. And Borrego Health services marginalized, low-income HIV individuals in the LGBT community. We work in the epicenter of HIV epidemic in Riverside County. The HIV prevalence rate in Palm Springs and North Palm Springs alone is 365 per 1,000 people, 12 points higher than the most recently available national rate of 291.5 per 100,000. This is from the HIV surveillance report from the CDC of 2013. An average of 5 people weekly are diagnosed with HIV in Riverside County and the Coachella Valley. Average 102 new cases of HIV per year. This is per the epidemiology, HIV and AIDS of Riverside County. Poverty heavily impacts our service population. In Riverside and San Bernardino County, people living with AIDS live below 300% of the federal poverty level at a rate of 95,691.5 per 100,000 as compared to 57,460.4 per 100,000 in general population. So you can see we're dealing with an impoverished group of people in our particular area. So what we've done is, as my daddy would say, you work smarter, you don't work harder. So we built our own residency program where we are going to grow our own. We don't have time to wait, so we've partnered up with different groups, and we train 39 residents per year. We then are going to then take and interview those groups to figure out who we can get as HIV specialists to stay and work with us. We are very grateful to have UCR here, and they in turn go out and bring those folks into their program who are the ones who are committed to staying here. So in other words, when they graduate, those graduates will stay here and work with this community. But those graduates won't come out until 2025. So we can't wait. So thus, we are getting our own group of folks together to help meet the need. We have something called patient-centered medical homes. And basically, that coordinates patient care across all elements of Borrego Health's care system, such as our specialty care, home health care services, community services, with an emphasis on efficient care transition. We achieve this by partnering with patients and families through an understanding of respect for culture, unique needs, preferences, and values. Our goals are to keep our patients in care, thus keeping their viral loads undetectable and decrease the risk of transmission. In the past year, we had 560 no-shows, and we have transportation. So we're dealing with the people. We're trying to reach out to them. But we have other barriers of care that we have to access. So one of the ways we're doing that is through telemedicine. I can't get all of my 7 providers out to my 24 sister clinics. So the best I can do is to set up telemedicine and get that patient to that particular clinic so they in turn can sit and at least interact with that particular provider. I have just recently implemented a policy and procedure where we have a standing order within the organization that we're following CDC guidelines, that if you fall between the ages of 13 and 64, you will be screened because we consider that just the gold standard of care. That way, we let them know we're decreasing that stigma, and we're here to take care of you. There's no sex shaming. There's no judging. We want you to feel at home so that we can take care of you. When we do STI screenings, we have quality care measures around that. We then use that as an opportunity to talk to people and educate them about PrEP. Because I have gone out into the community, and I have met with my own medical assistants who are mostly Latino and Mexicans, and some of them have never heard of PrEP before. I've had the opportunity to go sit and work in San Jacinto and outreach events where the majority of the people were African Americans, and when I was testing them, they were crying because the results were negative. So that then showed me, you were so upset that you got this negative result, so something is going on. So you're doing something, and once again, I'm not here to judge you, but I need to know that right now you're in care. And they shook their heads yes. Then the next question I asked them, have you ever heard of PrEP? Never heard of it before. So what we're also doing is we have Ryan White Part C funding, but only in San Bernardino, that at least allows us to do that early outreach to those folks to educate them, because the biggest barrier to care, once again, that we're finding is that people of color have never heard of PrEP before. So we're doing our best to try to address that particular issue. We also have our own in-house pharmacy, and they're our partners. So they know as much about HIV, well, not as much, but they can at least then follow up and partner with my providers. So in other words, I don't have to deal with someone going to Walgreens or CVS, but that's not to say they don't. Some of them do. But I can micromanage those particular patients that are working in my own particular clinic. So if anything happens, your insurance is running out. Guess what? My pharmacists have already found out about that. They're going to engage the folks they need to make sure that you don't run out of your HIV meds, because I'm not going to let that happen. So let's deal with some of the comorbidities and intersection to health disparities. This is a good one. Okay, so our biggest barrier to care is co-occurring medical and substance use disorders. We have clinics located, and they're located in identified mental health professional shortage areas, where there are 18,166 individuals per one psychiatrist. Okay, and this is per the Health Professional Shortage Area Mental Health Healthcare Atlas 2010. People living with HIV and AIDS have higher rates of mental illness than the general public, and too often mental health conditions go undiagnosed and untreated, which can create more barriers to care and cause interruptions in HIV treatment. This is according to HRSA. And mental health disorders are more common in the LGBT community. In a local survey, 78% of LGBT participants reported depression or anxiety diagnosed, while only 25.3% of adults in the Coachella Valley reported behavioral health concerns. This is according to the LGBT Community Health Needs Assessment of the Coachella Valley. The Inland Empire HIV Planning Council estimates that 73.3% of people living with AIDS in our service region are in need of mental health services. So what I'd love to see happen, if possible, is the ability to create affordable substance use disorders rehabilitation programs. Meth is a horrible, horrible thing that we have to deal with in the desert. So we don't have any place to send them. Once again, the closest place is LA. How am I going to get them to LA? It's not going to happen. They have to wait, as someone shared earlier, and they couldn't get into a program, so therefore they're lost and they're going back out in the streets. We'd also look at the possibility of creating at-home tele-behavioral or home-based services. And once we get them and we treat them, we have to have some sort of back-to-work programs, because the devil will find work for idle hands, okay? I've now cured you, but now you have nothing to do because you have no way to support yourself. But once again, if I've trained you or I've gotten you a trade, I've got you back to work, you have your own self-worth back as a human being. You're not going to go back on meth, because now you have a way of getting that house or that rental place because you got a job. That's something that we don't have, and I wish we had more of. So in conclusion, I thank you. If you have any questions, I will be quiet now and let you ask away.
Mr. De La Torre, go next, and then I'll have some follow-up questions.
My job as a linkage coordinator with AIDS Healthcare Foundation is to guide newly diagnosed individuals who are diagnosed with HIV into medical treatment, I also work with those individuals who were previously diagnosed, who need help navigating the system to getting back into medical treatment and connecting them to other services in the community. Currently, AHF has a healthcare center in the San Gabriel Valley in the city of El Monte, and one healthcare center in San Bernardino County in the city of Upland / Rancho Cucamonga. And soon we'll be opening a third healthcare center out in Riverside County in the city of Riverside. Today, I'm here to talk about some of the barriers that I've encountered working with the community, specifically HIV positive individuals in the Inland Empire and Pomona area. So some of the barriers that I've encountered is homelessness, addiction, lack of resources, and stigma, all of which are some of the reasons why individuals have difficulties accessing medical treatment and adhering to the regimen in order to stay virally suppressed and healthy. So currently, in the city of Pomona, there's about 5 places where you can get prevention services and free HIV testing and STI. So East Valley Health Center, Bienestar Human Services, Pomona Health Department, the Wright Medical Clinic Urgent Care, and Planned Parenthood. However, 2 of the 5 offer medical treatment for HIV, them being East Valley and the Pomona Health Department. Having only 2 HIV treatment providers in Pomona, we get a lot of referrals at our Rancho Cucamonga location, which we talked about earlier, how there's a shortage in providers in the area that deal with specifically HIV. So with this, because Pomona, I lost myself. Having only 2 HIV providers in, So because Pomona happens to land in the border of LA County and San Bernardino County, we find ourselves referring out a lot to either East Valley in West Covina or Covina, and then to our other healthcare center in El Monte. But a lot of our patients don't have access to transportation, which is another issue that was brought up earlier, how there isn't access to transportation. A lot of them have a fear of driving due to undocumented status or because they're not able to get a license. Additionally, many of these clients don't have health insurance and will need to apply for white services, and some have LA Medi-Cal. In addition, many of these clients do not have access to transportation, like I mentioned, or have a physical address due to homelessness. Having access to more local HIV providers in Pomona can reduce the wait time for new patients having to travel far distance to get into medical treatment and or accessing PrEP and PEP to prevent HIV. Finally, a wider spread of education and awareness messages can reduce stigma around HIV and AIDS and what it means to be HIV positive. Stigma is worsened in areas with less resources like Pomona and the IE because there isn't much cultural competent education, awareness, and campaigns compared to highly populated areas like Central LA and Western LA. Just the other day, I was working with a newly diagnosed patient who was living at his brother's house. His brother feared that his kids were in danger of contracting HIV due to his brother's HIV status and them sharing the same utensils or eating out of the same plate, and wanted to kick his brother out. And we were unable to find him a shelter that could take him in that same day. So situations like this further spreads a cultural belief that HIV/AIDS is still a taboo among many ethnicities and will need to more education and awareness around this issue. Sorry, I'm really nervous. Thank you. Mm-hmm.
Thank you very much. I appreciate both your presentation. I have just a couple questions. What steps can the state play in expanding PrEP and PEP uptake for people who ingest drugs?
So one of the biggest problems we find with PEP is that you can go to the ER and you can get medications for 3 days. Who's going to cover the cost of the medication for the next month? So even I can't help them because you have Gilead when it comes to PrEP, but who's going to do PEP when you've been exposed? So whether they, were IV drug users or the condom broke or someone was, God forbid, raped, there is not a whole lot we can do. Our hands are tied on that one. In regards to PrEP, we have grants that are in the Riverside area, and we have partners that are sitting in the room, and those partners actually help us. So I am grateful for the network of individuals sitting in this room, because as they say, it takes a village to raise a child. It's going to take a village and all of us to work together with the limited funding that we have, but we can play on each other's strengths.
Thank you very much. I was unaware of that. That's something we duly noted. What areas do you see, what areas haven't we discussed as you think that the state can play a more active and pivotal role in terms of tearing down barriers? I've noted transportation. We need to have more access in these areas that don't have access, but what else can we play? Because this is important for me to be able to go to Sacramento and advocate for some of these areas, along with those who represent the Inland Empire area as well.
It would be actually nice to see more funding in rural areas versus the funding that has happened in the urban areas. I look at San Francisco and how well they've done with their PrEP program. I'm proud of them. I laud them for what they've done, but they did it because they had money. So I would like to see that happen for the rural areas as well. We need to have that to create those PrEP outreach programs so that I can hire someone who looks like that person, who speaks that same language, who can go to that bar at night to where that person is and actually talk to them.
Good point. Anything else?
No, sir, I thank you for your time.
Well, that was great. Please give this panel a round of applause. Thank you very much. Next, we will have a discussion, and we want to bring up Mr. Maldonado once again. Oh, I'm sorry. I apologize. Discussion on substance abuse. Thank you very much for being patient. Please come up.
Hi, I'm Jennifer Bream. I'm the clinical director at Foothill AIDS Project, and Michael Maynard and I came together. He's a substance abuse clinician. We wanted to sort of demonstrate the comorbidity of these dynamics, that they tend to occur together, so we thought it'd be meaningful to sort of be here together to talk.
Great.
I really appreciate you pulling together this hearing. I used to be a school teacher before I got into mental health, and so I've been aware as a kinesthetic learner of the challenge of sitting for this long. So I wouldn't begrudge 1 minute of our time if people wanted to like stand up, say hello to your neighbor, not to take over your meeting, but it's hard to sit for 4 hours. And it's hard to go last, too.
Well, hopefully the best for last.
Okay, I like it. Nobody wants to stand up and say hi to your neighbor, that's okay. So a number of the presenters have talked about the lack of experts in the field. I definitely came into the field not as an expert. I have 17 years as a mental health professional. 7 years ago, I started working in HIV, and I came to the setting with no background or experience in HIV, and I don't think I'm rare. In my experience, it tends to be two categories of people who are drawn to working in this field. It tends to be people of faith, people from the LGBT community, and of course there can be a lot of intersection between those groups, and there tends to be a commonality. I think that we see it as a calling to sort of work among the marginalized, those who tend to feel on the outskirts of society. So I came to this work pretty clueless. A lot of what our agency does is train our staff. We know that that's a task that we face, and so we do a good job of providing a lot of training and education. A lot of our education is given to us by our clients, and they don't seem to resent that, and they're very generous in just sharing their stories with us. And as mental health and substance abuse clinicians, we get to be on the front seat to sort of hear the stories of their lives and what they encounter. And that's been the most valuable education, I must say. So prior to coming to Foothill AIDS Project, I worked with homeless people, low-income individuals, mostly minority populations. I'm sure a lot of those were HIV positive, but I never knew it. Those settings in which I worked didn't provide the opportunity to even have that conversation or ask that question or for people to disclose that status. It wasn't part of any assessment. And I think that that's really important, that it not be so specialized that it's not available in the broader community of people seeking services. When I got the flyer about this meeting, I was sort of hard-pressed to know how to engage this conversation, because I can't talk about barriers without immediately talking about, okay, so what are we gonna do? What are we gonna do? And maybe it's true of a lot of providers in the Inland Empire that if you're used to having a paucity of funding, that if you have a passion and a love, you are automatically going to be solution focused, and it's going to drive you to be innovative. And so it can be a mixed blessing. So I'm not only going to talk about the challenges, but I want to talk about what has worked too, because in the 7 years of doing this, we've learned a lot about what not to do and what seems to be working better. I come from a traditional background of kind of top-down treatment. So we sit somebody down, we assess them, we give them a diagnosis. I'm not sure, a diagnosis might help us as clinicians. I'm not sure it helps clients to have a label affixed to them. We make a treatment plan. Traditionally that's been, I'm a clinician, I'm a professional, I'm gonna make a treatment plan and tell you what you need to do and help you. I think a huge shift that's been very helpful is a shift toward motivational interviewing, which really focuses on sitting down, asking a lot of questions and getting to know the individual in front of you to understand what's important to them, what they're motivated to pursue, not to assume anything. We've also found it very helpful to work from a harm reduction perspective, which is meeting our clients where they are. If they come to us actively using substances, not to expect or require that they're going to cease and desist that behavior right away, or probably absent of a oftentimes arduous journey. So our goal is to stay in relationship with them and build that relationship so they know where to come for help. We've also found with our largely minority population that emphasizing groups has been really helpful, that people who are HIV positive could come to a room full of people who look like them, who share their experience, who welcome them into a real family kind of environment. We started with 2 groups, we now have 13. And as has been said several times, untreated mental illness keeps people in isolation. Isolation probably contributes to people being involved in high-risk behavior. So which is going to be perpetuating infections. So I feel like our main benefit and the main purpose in our providing treatment is that we provide surrogate family for people who feel very disenfranchised and stigmatized and isolated. And so we provide, people get hurt in relationship, they get healed in relationship. So being there, being consistent, and trying to be that surrogate family has been, seemed to really make a difference. It's really helped us build community where there's been a lack of community. There's been conversation about intersecting with communities of faith. I very much agree with that, and I think it may fall to we as people working in the field to reach across, to initiate conversation that includes listening, so that it's a respectful conversation that appreciates the perspective of people coming from a faith-based community, and also appreciates the influence that when someone is having a mental health challenge or a crisis like HIV, they're more likely to reach out to their pastor or their priest before they would come see me as a therapist. So to really respect that relationship and to try to build on it and collaborate with it, I think. And so everything we've been talking about today, I feel like it's all interconnected. This is, we're focusing at this moment on mental health and substance use, but it all works together. And so what we've found is most effective is to work in a multidisciplinary setting as a multidisciplinary team. So we case conference across disciplines and we talk together about housing, substance use, medical case management, and talk together about the relationships that we have with these clients. So I think integrated treatment is one of the most effective ways that we can make a difference and see change. That's kind of my main.
Well, thank you for giving us a voice here today. Appreciated a chance to bring this information to you. I've been in the addiction treatment field for the last 10 years. I've worked with different populations from celebrity rehab to methadone clinic. I have been an interventionist, over 60 successful interventions. So having said that, the data that I have to draw from is pretty deep. And I wanted to start by revisiting, there was a lot of statistics today that was given out, a lot of information. I just wanted to circle back to one of our presenters earlier stated that they were showing some statistics as far as transmission of HIV. And the number one was 65% was unsafe sex or risky behavior. And they stated that 3.4% was IV drug use. And I think that this is a little misleading. I think that unless you understand this, the narrative behind it, I think that it tends to look like, well, gee, the drug issue maybe is a small percent, but behind this 65% is drug and alcohol use, the risky behavior, unsafe sex. So I think you really have to look at that and understand that behind that is drugs and alcohol. And therefore, I think does a better job at narrating the enormity of the problem as it relates to HIV. And so, having said that also, I think the importance is there's some information that I recently came across as stated in 2009 there were 20 million people in America that identified as problematic substance use. In 2017, the estimates are 60 million, almost 3 times in that period of time, identify as problematic substance use. So I just wanted to clarify the enormity of substance abuse as it relates especially to this population. One of the things that I also heard that the point that I'm going to make is the story that one of our presenters gave us about the story about the person who was ready for treatment, but there was no treatment available. And that is really, that's my point, is that we are not really putting enough emphasis on substance abuse and addiction as it relates to the HIV community. The statistics that I've come across don't have a narrative. It's not explained. If you weren't familiar with it, you wouldn't really know how to look at that. And one of the problems or solutions that I wanted to express was that we need to do more outreach. One of the we are putting out fires with substance abuse. Only those severe cases are the ones that are getting the attention. And then, after working with a client for a period of time through the stages of change, bringing them to a point where they surrender for treatment, not to have treatment available. And it needs to be on demand. That is just, it's a crime that we don't have the resources to get these people into it. So we're talking about Medi-Cal on county funding. there just aren't enough beds. There just aren't enough beds. And I know we have some changes coming in January. Medi-Cal is going to be a predominant payer for our population. So far they've rolled that out in Riverside, and it's been problematic. We haven't had very much success with getting people into treatment through this new program. So there's a lot of concerns. I think that we're really taking a look at substance abuse in this equation as it should. So how can we do this outreach? Low and moderate risk, so we're getting ahead of it. Low and moderate risk individuals for substance abuse. We need to be doing outreach, preventative measures. We need more on-demand inpatient treatment available for this population. And also something that's not talked about a lot is family engagement. The ability and resources to bring families into the fold when it comes to treatment and recovery. That's all I have.
Thank you very much. Appreciate it. Let's give them a round of applause. What was your name again? Jennifer, you said something, how you came to this work, right? And it just jogged something in my memory in terms of how I came into this work. It was certainly not something I selected. It was born out of some hurt and pain. This is long before I got elected because I lost 2 people who I loved very much due to the virus. And I became the godfather of their child who has no mother, no father. And then subsequent to that, I've had to say goodbye to a number of my friends like Rod, Patrick, Sean, Eric, Jose, Victoria, Kelly, Ruben, Robin, Omar, Jesus, and Eddie. So this work is very real. And I commend each and every one of you for, one, taking on this fight with all of us to hopefully get to 0 new cases, new deaths in this state, in this country, because it's going to take all of us collectively. And even though sometimes this is not the work that we set out on our course to even endeavor, but it's the fight that we find ourselves in. And the only way we're going to actually win this fight if we all work together. So thank you very much.
Thank you.
I want to invite Mr. Maldonado to come back up and join us again.
So in an effort to not be duplicative or redundant, and my colleagues and my friends, and really this is my family here, they've done an amazing job at capturing the information, and I think it would really take an entire hearing for me to summarize everything all over again. So I'm just going to leave with a couple of points, and understanding if my colleagues can just give me deference. Obviously, I'm not going to be able to fully encapsulate all of the things that we want to see in our community, but I'm just going to try my best. So some very poignant areas that I think the state can work on specifically is I will first speak broadly about the public health issue, and then I'll give a couple of recommendations that fall squarely within legislative charges. So the first one is expanded access to HIV testing, both storefront and mobile testing. So I think that both of them are needed, particularly as Dr. Ohikware noted that we have such a large geography. So replicating some of the Get Tested Coachella model, if there could be 10 Get Tested Coachellas all between San Bernardino and Riverside County, that could make a difference in terms of the geography. The second one is expanded access to PrEP education, PrEP navigators, and PrEP linkage. That is something that's very crucial. Expanded access to PEP services. I had a thought right now about maybe some kind of legislative requirement in which hospitals, instead of giving out 3-day dosages, are actually required to give out the full 30 days. I don't know, throwing that out there. I'm sure there's tons of issues and parameters, but that's just a food for thought moment. The fourth one really deals with social determinants of health and comorbidities, and that, I would say, is not only a jurisdictional problem, but it's a statewide problem, it's a federal problem to look at things like housing, transportation, substance abuse, mental health, and I think we're going to really have to need to address the core infrastructure of our healthcare apparatus to really get at that. I'm not touching on that so much because I had a thought. As far as jurisdictionally, my colleagues and my providers here, they have the working models and the solutions. I think sometimes one of the first things I learned when I came to work at the President's Advisory Councils, the first thing they told me was, be careful to not reinvent the wheel. That was the first thing I was given recommendations when I was appointed. And I don't want to reinvent the wheel. There are already innovative projects that are being done. There are already initiatives that are being undertaken. People like Foothill AIDS Project, Desert AIDS Project, Borrego, even our up-and-coming community-based organizations like Families Living with AIDS Care Centers. Curtis Smith is here addressing the western region of Riverside County. There is already innovative projects that are problem-solving solutions that are being created. What we really need and what the real call is for infrastructure dollars. And I know that word is sometimes a dirty word in legislation because it's so nuanced, it's large, it's not always outcome driven, but really we need more brick and mortar facilities. We need more injection of funding into existing programs that are already here. And I'm specifically noting the $80 million that was cut from the state budget in 2008 by Governor Schwarzenegger, and we've never really seen those dollars come back in. And so while there are many organizations that are doing amazing work to try and lobby for those dollars, particularly the California HIV Alliance that has done a lot of lobbying and advocacy around that, we don't need $1 million back. We don't need $10 million back. We don't even need $80 million back because that was in 2008. We really need $100 million, or whatever it is, the formula that we design and come up with about where the gaps are in the entire state of California. So if we can look at addressing that zeroing out of that line item that took place in 2008, that would be a good place to begin. And so that is kind of what I would like to leave us with. I think we're going to have to revisit this conversation over and over and over again, and this is one of many follow-up meetings yet to come. But that is just my summary. And then my policy coordinator, CL Rivas, took a copious amount of notes for us, so on everyone's comments and feedback. So we will summarize that and we'll send it over to you afterwards. So that is my statement, and I yield the floor.
Thank you very much. I appreciate that. Let's give Mr. Maldonado a round of applause. Thank you very, very much. I think you summed it up very, very well, and I appreciate receiving any notes, any PowerPoints. Please share that with us because we want to be very deliberate when we articulate what transpired here today. We want to take an opportunity to open it up for the public's comments. I believe we have that podium to my left, maybe your right, is designed for public comments. We have 2 minutes. If anyone chooses to address this body, we would love to hear from you. So 2 minutes at that podium, and we'll be keeping track of your 2 minutes. Please state your name, any organization that you represent.
Good afternoon, Assemblyman. I'm Gary Rada. I'm the Senior Vice President for Government and Public Affairs at Borrego Health. I work closely with Chuck, who does a great job with, with best practices, clinical work. I handle the policy side of things. I just want to mention 2 things that you and your colleagues did this past year that I think can be used and followed up by your select committee. One of which was SB 323. Which had to do with drug Medi-Cal, with the provision of services and the ability of community clinics and health centers to contract with counties on behalf of the substance use dollars and services, and clarified that community clinics can do so. And I would like to suggest to you that your committee may want to follow up and ask, how is that going? And see how many health centers have attempted to apply, how many have been successful, and what the barriers or impediments may have been to the policy change that the legislature made. And the other thing was in the state budget, the legislature pushed hard and put additional funds for residency programs through OSHPD into Song Brown. And you may want to consider that as part of that 3-year residency program, that the 3rd year that there be points given to those health centers that apply for residency programs and for this funding, additional points given to those that are willing to adopt as part of the third-year residency, special fellowships to be able to increase the knowledge of providers to be able to do the types of services that we're talking about today as a way to fill the shortfall in the workforce shortage that we have.
Thank you very much. Under 2 minutes. Thank you.
Thank you, Assemblyman and Gibson. It's an honor to be here today. Being an African-American family that migrated from South Central LA to a rural, conservative county, it was very challenging for us as a family. And that was the birth of the Families Living with AIDS Care Center. And so just to piggyback on what Gabriel Maldonado said in relationship to the infrastructure funding, we out of Riverside County, we have a successful collaboration in testing in the rural area. And you might see in the green, the service area 2, there is no provider, but we're there. The care center is there. And I just want to thank Borrego Health and True Evolution for collaborating with us. Also, Danny Burke, who is here, who's starting the LGBTQ Center, who is implementing the Live Now program that we have, which is our therapeutic prevention, and it deals with the coping. How do you cope and deal with living with HIV, and how do you get past that? What is your end game? So please, really look at that infrastructure funding.
Thank you very much.
Hello again, Anthony Brazier, Foothill AIDS Project, and again, you just to kind of hone in on the disparities of the communities of African descent, and I've been around actually since 1996, and that has always been the trend and the data, and it hasn't changed. 20 plus years later, I am hugely concerned. I've been hugely concerned about it. And it doesn't seem like we are getting close to lowering those, to bring down that data. What's happening? Why aren't the Black community getting the message? What's going on? This is a long time being at the top of the disparity rates. And so that's just my comment.
Thank you very much.
Hi, Assemblymember Gibson. Thank you, and thank you, everyone. My name is Robin Schweizer. I'm a social worker and program manager at Bonita Human Services. I work out of Pomona. We are a community-based organization that's in Los Angeles County, but being in Pomona, we are on the cusp of San Bernardino County, and so a lot of our clients come from San Bernardino County, so it's really helpful for me to come here and learn more about the services that are in Riverside and San Bernardino counties that we can offer the clients that do come in. At Bienestar, we do have a syringe exchange program. We are one of the few syringe exchange programs in Southern California and in Los Angeles County. We are working on getting that in Pomona, but right now it's only in our East Los Angeles location. And at our syringe exchange program, we not offer syringe exchange or syringes, but also the supplies needed, as well as Narcan, and also education and other resources for some of our other programs, including HIV testing, Hep C testing, and mental health services and substance use services if clients are wanting more than just coming in for syringes, and also a safe place to come in and just talk. And that's something that, I think harm reduction is something that the state can look into a little bit more, and how maybe some more research, especially out here in San Bernardino County and in Los Angeles County at the local level, maybe more research and investment in syringe exchange and harm reduction strategies in general and their efficacy and how helpful they can be to clients, and even in getting them to other services such as mental health services and in HIV testing. That's something that we do too. We provide it at our storefront, but we also do it in our mobile testing units. And we go out to other areas in Los Angeles County where our clients are, and we reach them with syringes and HIV testing, as well as Hep C testing. We are working to get Hep C testing at our Pomona Center right now, along with the syringe exchange program, but we will for sure have Hep C testing there. That's kind of our problem right now too, is with the local government. We're working on talking with them because they can be, it's somewhat, perhaps, I know we had tried maybe 10 years ago in the past, and it was more conservative at that time. But I do think that, yeah, working on maybe some more research and some more funding and harm reduction, and working in collaboration with other organizations or such as the Harm Reduction Coalition and Drug Policy Alliance. Thank you.
Thank you very much. Is there any additional public comment? Hearing and seeing none. Let me say thank you very much to all of our presenters, our panelists, and to all of you for coming out and being part of this very important discussion. I appreciate each and every one of you. You certainly have given us a lot of information that we will take back to Sacramento and share with my colleagues, especially those who represent the IE. As a chair of the Select Committee in high-risk disadvantaged communities, I take this job and the particular mission very, very serious. I want to thank our speaker, Anthony Rendon, for one, having the confidence in me and appointing me to this position. I also want to thank the Democratic Caucus of Communication and Outreach, who's with us, who is videotaping this entire hearing. These are the silent individuals in the back with the cameras and taking pictures. Thank them for their time. And also my own team, Mr. Jay Jefferson, who sits to my left, who heads up my Ledge division in the state capitol, flew down here from Sacramento to be here. And also thank you for interacting with him to make today hearing possible. Mr. Victor Ibarra, who's in my district office, who heads up these kinds of issues around the LGBT issues, is standing in the back. He greeted you as you came in. So I have a whole host of team who've helped me monitor and facilitate these particular hearings, which are, again, are vital and important. Let me say this in conclusion. You have certainly given me a lot of nuggets to take back, and I believe my legislative plate will be full. Exploring a number of the ideals that Mr. Maldonado has articulated in his summary of everyone's articulation here today. I want to make sure that we continue to dialogue. Please contact me. Please reach out to me, email me, reach out to my office. Let me know that you were here, and these are some of your thoughts that you thought about when you headed the pillow tonight or on the drive home, or like me, when I'm in a gym, that's when I get most of my brain started flowing and things of that nature. Whenever you get those ideas, please share those with me so that together we can try to get to 0 new infectious cases in this state. So again, thank you very, very much. Let me pause for a moment. Have I forgot anything? Feliz Navidad, Merry Christmas, have a great holiday. Thank you so very much.